is going to be over by this. Everybody has taken that. Family has taken more time.
अगर आपको कहीं पर डाउट है कि कौन सा रेडियो ट्रेसर यूज होना है तो यू कैन जस्ट राइट की पेट स्कैन फॉर प्रोस्टेट कैंसर। वो हम समझ जाएंगे कि पीएसएम है। पेट स्कैन टू लुक फॉर न्यूरोएंडोक्राइन ट्यूमर। दैट इज ब्रॉड वन। हाँ हाँ। तो जैसे आप सीटी या एमआरआई रेफर करते हो, आप ये नहीं बोलते जाके सीटी करा के जाके एमआरआई, आप क्योंकि एनाटॉमिकल इमेजिंग है, आप एक रीजन स्पेसिफाई करते हो। सीटी नेक, सीटी चेस्ट, सीटी एब्डोमेन, एमआरआई शोल्डर, एमआरआई पेल्विस, एमआरआई वॉल स्पाइन। वैसे पेट सीटी जो जब आप बोलते हैं ना कि जाके पेट करा के, पेट तो मशीन है सर, उसमें अलग अलग रेडियो ट्रेसर है कई बार। बट हम कहाँ पे फंस जाते हैं? पेट स्कैन फॉर प्रोस्टेट कैंसर। पेशेंट पूछता है सर ये कहाँ पे होगा? एक्स वाई जेड जगह पे। अच्छा कितने का है सर? 10-12 हज़ार का होगा। पेशेंट मेरे पास आता है, मैं देखता हूँ पेट स्कैन फॉर प्रोस्टेट कैंसर एफडीजी में 10-12 हज़ार में कर सकता हूँ, बट मैं पीएसएम स्कैन 10-12 हज़ार में नहीं कर सकता। I mean there is a price difference between FDG PET, PSMA PET and total of PET in general in market. So जहाँ पे पेशेंट को ये पता होता है कि ये इसी रेट पे होगा, जैसे ही मैं बोलता हूँ नहीं आपका तो PSMA स्कैन होगा, आपको 6,000 ज्यादा देना है, पेशेंट बोलता है तो पागल बना रहे।
Second is regarding the response evaluation. Like in CA breast, we are giving a neoadjuvant chemo. After how many cycles we should go for PET scan, and what are the criteria on PET that patient is responding?
Particular therapy आता है. So after 3 cycle of therapy. दूसरा क्वेश्चन आपका था कि कितने
टाइम तो हो गया. What's the criteria that case is responding?
हाँ, उसमें क्या है वो क्राइटेरिया हम क्या करते हैं, हम persist और resist क्राइटेरिया लगाते हैं। हमारा क्या होता है कि अगर सपोज पेशेंट का डिजीज 30% रिड्यूस हुई है तो हम उसको पार्शियल रिस्पांस देते हैं। मतलब किसी को सपोज अगर ये 10 सेंटीमीटर था, अब 7 सेंटीमीटर से कम हो गया है तो हम बोलेंगे तो पेशेंट है इस पार्शियल रिस्पांस। अगर कंप्लीट चला गया, 10 का 10 खत्म हो गया, वी विल से कंप्लीट रिस्पांस।
So it's the morphology, not the SUV.
SUV के बेसिस पे हम लेते हैं, बट वो सिनेरियो में लेते हैं जब हमें पता है कि स्टैंडर्डाइजेशन प्रॉपर हुई है। कब स्टैंडर्डाइजेशन प्रॉपर हुई है? हमने डोज 10 मिली क्यूरी दी है, हमने उसके बाद जो इमेज एक्वायर करनी है, सपोज वी हैव डन at appropriate time. Normally the appropriate time is 1 hour, and the blood sugar at the time of previous scan and at the time of this scan, that should be, I will not say exactly the same, but they should be near to each other. So these criteria, there are many other criteria. If we are standardizing the weight, if we have done all this standardization, then the response evaluation with the SUV is also appropriate. If we will not say we will not do with the SUV max. Yes, it can be done with SUV max, and that SUV max response will be more appropriate rather than assessing the morphological response. But we have a problem over here in our country. If the patient this time will go to the one center and other time it may go to the other center. So problem will come that each center has slightly different criteria. Number 2, आज इंजेक्ट किया पेशेंट को तो इस बार पेशेंट का नंबर आ गया 1 घंटे में, अगले बार 1.5 घंटे में आएगा। So हम वो करेक्शन फैक्टर प्रॉपर लगाएंगे तो डेफिनेटली वी आर गोइंग टू गिव द SUV max value on the basis that the patient is responding or not. वो persist क्राइटेरिया होगा। जो resist क्राइटेरिया है वो सिर्फ on the basis of size है, but persist क्राइटेरिया also take PET CT into the criteria.
So one should get this follow-up PET from the same center
and instruct them कि आप ऐसा ही करना, जैसे हम वहाँ नहीं कर पाते। हमारे पेशेंट सवेरे 9 बजे आता है, शाम को 9 बजे जाता है। So we are sorry that कि हमें सबको 50-60 पेशेंट करने होते हैं। So it is not humanly possible to do the standardization. उस केस में हम क्या करते हैं, हम जो है विजुअल एनालिसिस करते हैं। विजुअल एनालिसिस करते हैं मतलब हमें पता चल गया पहले SUV है और अभी SUV है, पेशेंट पहले 5 थी अभी 7 हो गई है, फिर भी हम रिस्पॉन्स देते हैं on the basis of our clinical experience, on the basis of other things. So उसमें क्या होता है कि वो हम कर लेते हैं, वो विद एक्सपीरियंस हमारा आ जाता है। But it may not be easy for every center and everybody, क्योंकि जो न्यू लर्नर होते हैं they may not be able to do this.
Thank you.
Okay, sir. Just a minute. Last question, ma'am. In breast carcinoma, we are doing PET scan for staging purposes. So it is a conventional teaching that every metastasis has to be proved histopathologically. Is there any relevance if we are getting metastasis on PET? Should it be done confirmed by histopathic, or just will say on PET metastatic, so disease is metastatic?
See, होता क्या है कि आइडियली तो नॉर्मली तो क्या करना चाहिए कि मेटास्टेसिस को प्रूव करना चाहिए जैसे आपने बोला है, बट दिस इज नॉट फिजिबल इवन इन द वेस्टर्न सेटअप। अगर सपोज किसी पेशेंट को लीवर में सेगमेंट 1 पे मेटास्टेसिस है, तो गोइंग देयर इन सेगमेंट 1 ऑफ द लीवर एंड गेटिंग द सैंपल फ्रॉम दैट साइड इट इज नॉट पॉसिबल. सो होता क्या है, देयर इज नो अदर डिफरेंशियल फॉर दिस. अगर देयर इज अ मेटास्टेसिस इन द liver, so what else specially is having CA breast, there is a lesion which is metabolically active and vertebral lesion. So मतलब अदर डिफरेंशियल डायग्नोसिस है कोई नहीं है. सो वी विल कंसीडर दिस इज द मेटास्टेसिस. तो उसका तरीका और भी है कि फॉलोअप में आता है हमारे पे, वो रिस्पॉन्ड करता है नहीं रिस्पॉन्ड करता, बट बाय एंड लार्ज दैट इज मेटास्टेटिक. जहां पे हमें लगता है कि हमें जैसे मीडियास्टेनल लिम्फ नोड है, हाँ ब्रेस्ट कैंसर पेशेंट आया, उसको मीडियास्टेनल लिम्फ नोड आया, तो मैं बोलूंगा हम एक लेंगे, एक न्यूक्लियर मेडिसिन फिजिशियन बोलेगा ये मेटास्टेटिक है, दूसरा बोलेगा ये मेटास्टेटिक नहीं है. सो फिर तो क्लिनिशियन कंफ्यूजन हो गया. फिर आप क्या करोगे, वहां पे आप हिस्टोपैथोलॉजी करना. वहां पे अगर आपको होता है सैंपलिंग तो कर लो. जो एरिया कंफ्यूजन वाले हैं, जैसे सुप्राक्लैविकुलर लिम्फ नोड है, इजीली एक्सेसिबल है, गो एंड डू द एफएनएसी. But the patient having the vertebral metastasis, it is not due to the biopsy over there. So it is better to believe nuclear medicine physician and particularly from all
What about the medico-legal aspect of that? No?
I think that is proven and accepted that if the PET CT has proven that this is a metastatic, so we should know that is a metastatic.
See, even in the court of law, if there are no proof, then they go by circumstantial evidence. So it is not that even in the court of law you want to justify that if it is not there is a proof of histopathology, then
Also, if I
डॉक्टर मनोज सॉरी मैंने वैसे मजाक किया था, वो आप मुझे पता था उसके बाद मेरे पूछने वाले हो, बट वो जस्ट जोक किया था.
नहीं
आई नो राजीव गांधी में बहुत अच्छा.
डॉक्टर मनोज गुप्ता राजीव गांधी कैंसर will tell you our practice.
I think what the Dr. Shamim is saying, most of the time when there is vast metastasis, okay, then the question of histopathology is not there. The problem comes what the Dr. Shamim has shown, there is a single metastasis, and now your treatment management is changing from the curative to palliative. Then the problem comes. So in those scenarios where the management is changing, you need to prove it, or at least you should attempt to prove it. Otherwise, later on there will be an issue, as you said.
Similarly, we had a early breast carcinoma patient. ठीक है, but on the basis patient wants कि मेरा whole body fat करना, so we referred the patient, and on that, as you said rightly said, sir, there is very small nodule in the liver. That is FTG. Dr. Praveen has done that. ठीक है, so we are not
Able to even get a FNAC done out of that. ठीक है, but whole management changing. It is from early breast carcinoma, it changes into metastatic breast carcinoma. Then there must be something. Everyone, it depends what sir is saying. If the case goes for medical examination to Karwasra, sir is rightly said yes, okay, there are circumstantial evidence. If goes to some conventional surgeon, he will say it is metastatic but has to be proved histopathologically. That's why I am asking this question. And one more question I am adding, sir. We have operated a CA colon patient with mediastinal FDG PET positive patient. ठीक है, तो it turns out to be metastasis. But patient goes to Gangaram, they have done FNAC from that, and later on that mediastinal nodes turn out to be tuberculous. So these things are changing, है ना? Every way, because every new thing is coming, it has some. That's why I am asking particularly this question: in metastatic disease, whether it has to be proven or not. That is a
See, जब इसमें मैं आपके दो आंसर दूंगा, थोड़ा सा क्लियर दूंगा. जैसे ये पेशेंट है, आप देख लो, इसमें ये लीजन है, ब्रेस्ट कैंसर है. इसमें हम क्या करते हैं, देयर इज नो अदर डिफरेंशियल फॉर दिस मेटास्टेसिस. इस लीजन के लिए देयर इज नो अदर डिफरेंशियल. इन्फेक्शन विल नॉट बी लाइक दिस, कोई बिनाइन लीजन विल नॉट बी दिस. वी हैव सीए ब्रेस्ट एंड देयर इज a लीजन टू प्रूव दिस टाइप ऑफ लीजन, व्हिच आई विल से एंड दे विल क्वेश्चन आपने क्या बोला था कि सपोज मीडियास्टेनल, आप सीए कोलन से मीडियास्टेनल लिम्फ नोड जाना और वहां जाके मेटास्टेसिस करना, जिसने वो मेटास्टेसिस दिया है, मतलब वो भी मुझे लगता है कि एप्रोप्रिएट रिपोर्टिंग नहीं. तो in that case आपको मीडियास्टेनल लिम्फ नोड इज नॉट द रीजनल लिम्फ नोड फ्रॉम द सीए कोलन. उस केस में अगर आपको स्ट्रांग सस्पिशन, कभी-कभी हो सकता है, आप लिटरेचर में जाओगे तो आपको 10 केस मिल जाएंगे कोलन विद मेटास्टेसिस टू मीडियास्टेनल लिम्फ नोड. बट इन दैट केस मैं आपकी रिपोर्टिंग में तो मैं ऐसे लिखता हूं this mediastinal lymph node more likely to be infective. अगर मुझे strong suspicion लगता है तो मैं clinician को बोलता हूँ kindly prove this. Otherwise I will say you don't need to prove this. So in that scenario we need to be like this. You have to discuss with the clinician.
सर अभी एक नया रेडियो टेस्ट है, तो since last 3-4 months I am doing FAPI. FAPI में ये FAPI malignancy specific. तो उसमें जो 3-4 महीने का मेरा एक्सपीरियंस है, उसमें ऐसे कोई भी लीजन जिसका FDG पे डाउट है, whether that is metastatic or that is not malignant, उसमें FAPI करके मेरा ये एक्सपीरियंस है, FAPI gives you a clearer picture.
We need to move on.
Slightly different.
Mediastinum is always going to be a questionable area.
और 30 में भी आता है ऐसा.
I think we are modern way. FAPI is again is a non-specific research, so to differentiate between benign and malignancy is difficult. I think the right answer is the FES scan because the estrogen imaging. So if you have a very strong, ER positive breast lesion, then probably the FES scan can help you. If the FES is positive in this lesion, then probably you can avoid a biopsy.
I
Otherwise, you need to
think
do a biopsy.
we are going far ahead. For our general audience, FES is not easily available. So everybody knows FEG
And
PET.
that will confuse them more.
Yeah, so
So
let's not
FES, I
confuse.
think we better avoid this.
Yeah, in the gynecology side, two questions. Most of the time you get
But
patients.
can पूछिए ना आपसे, permitted है ना?
So, for the most common patient we get sometimes in postmenopausal with slightly large ovaries, SITs and menstrual disorders. So we suspect tuberculosis or malignancy. So why these PET scan can differentiate between tuberculosis or malignancy?
मैडम ये क्वेश्चन तो आपने उसके लास्ट में पूछा और बता दिया है.
One more question.
हाँ टफ क्वेश्चन है, इसलिए हमारे पास इसका आंसर क्लियरली नहीं है. ये फैक्ट दोनों में अपडेट आई है. ओवेरियन जो है नॉर्मली पोस्ट मेनोपॉजल मूवमेंट में ओवेरियन में कोई अपडेट नहीं आती. अगर कोई अपडेट है तो वो पैथोलॉजिकल है. प्री मेनोपॉजल में तो चलो क्योंकि फेलिकुलर हो गई. अगर उसकी अपडेट आई है तो फिर इट कुड बी मैलिग्नेंसी, इट कुड बी ट्यूबरकुलोसिस. फिर हम क्या करते हैं हम टेलटेल साइन देखते हैं. टेलटेल साइंस मतलब पेशेंट को कोई और लीजन है कि नहीं है, उसकी कैरेक्टरिस्टिक्स कैसी है. जैसे ट्यूबरकुलोसिस आपको पेरिटोनियल डिपॉजिट नहीं दिखा नॉर्मली, हालांकि मैंने ऐसे केसेस भी देखे, कल भी देखा है जिसमें पेरिटोनियल डिपॉजिट थे पूरे तो. बट नॉर्मली जो होते हैं बाकी CA125 इतना दोनों में होता है, दोनों में रेट होगा. बट ओवरी में क्या होगा, हंड्रेड्स में होगा, 700 होगा, 800 होगा. उसमें क्या होगा 50, 100, 200 नहीं वो भी. दैट इज आल्सो नॉट एब्सोल्यूट क्राइटेरिया. आई एग्री विद यू. मुझे पता था आप उसके बाद यही बोलेंगे. सो मैं कह रहा हूँ कि फिर हम एक एविडेंस की बेसिस पे नहीं करते हैं, फिर 4-5 एविडेंस की बात करते हैं. और अगर हमारे को पता नहीं चलता हम बोलते हैं गो लेट विद क्लिनिकल. फिर आप आपका हाथ खड़ा कर देते हैं, आपके ऊपर रिस्पांसिबिलिटी.
Low grade and high grade depending on the uptake, radiography uptake.
In general will come.
The uptake will be higher or lower, whether independent of this. That
Yes, very valid question. जिनमें अपटेक कम होती है वो ट्यूमर जनरली जो होते हैं लो ग्रेड जनरली. बट अगेन इस रूल की एक्सेप्शंस हैं बहुत सारी. मैं बताता हूँ सिग्नेट सेल ट्यूमर स्टमक का वो बहुत कम अपटेक देता है, एग्रेसिव होता है. RCC कम अपटेक होती है, एग्रेसिव होता है. सो इन जनरल जैसे लंग में आपको अगर लिम्फोमा में आपको अपटेक कम मिली तो लेस एग्रेसिव है, ज्यादा हुई तो हाईली एग्रेसिव है. तो नॉट दिस रूल विल नॉट होल्ड ट्रू इन एवरी केस. सो दिस इज डिफरेंट फॉर डिफरेंट केस.
What is 30? Just
30 आपने ठीक किया आपने. 30 इसी तरीके से है मैडम. जैसे हम पहले क्या करते थे, हमारे इंडियन कल्चर होता था तो हम रोटी खाते थे. हाँ हम रोटी खाते थे. अच्छा पहले क्या था, हम इंडियन रोटी थी. हम क्या कहते थे, इंडियन वाले रोटी चावल दाल खाते थे. तो अब क्या हो गया, हमारे को ब्रेड भी आ गए, हमारे को ऐसे ट्रेसर फैट सिटी के ऐड होते जा रहे हैं. तो एक और ऐड हो गया है हमारे, एक इसमें हमारे को फायदे हैं.
As Dr. Snmi told, we look for some other features on the scan which may direct towards either malignancy or tuberculosis. There was FDG avid abscess lying along the margin of acetabulum, and that FDG avid we reported that it probably is tubercular. Then the patient was, this abscess was aspirated from peritoneal thickening. And CA125 was. So patient again suspected case probably ovarian malignancy. You get a PET scan done. We did a PET scan. So FDG PET we did. You can see, omental peritoneal thickening, all are FDG avid along with ascites, but uterus and adnexa they are clear. So chance of having ovarian malignancy was less. That time we were starting FAPI. That was our initial days. I tried to do FAPI on this patient, and as you can see, there is also FAPI uptake along the omentum and peritoneal disease, but the intensity of uptake is more on FDG. So my assumption was that since FDG is more avid, FAPI is less avid, so I reported it probably this is non-malignant, it may be tuberculous. But that was not digestible to my treating physician. But she was saying patient is in Australia since last 12 years and he was saying abdominal tuberculosis. I mean, this cannot be done. So let's do omental biopsy. When they did laparoscopy, what they saw, dirty looking ascitic fluid, peritoneal lavage was done, and the final diagnosis was intense aseptic peritoneal inflammation secondary to intra-abdominal spillage of ovarian cystic fluid. When the ovarian cystectomy was done, it ruptured, fluid disseminated inside the peritoneum, and that led to aseptic inflammation. So after peritoneal lavage, within 12 hours, CRP decreased from 200 to 58, and patient became afibraned in 24 hours and discharged on post-op day 2. Now case 8 and 9, coming to tuberculosis, maladies of all disease in India, how TB can mimic like anything. This case is that. So on your this case 8, as you can see, FDG avid mass in the abdomen, and here another FDG, inhomogeneously FDG avid mass in the abdomen. Apart from that, there are lung lesions, pleural lesions, both have bone lesions. See, FDG avid mass, as you can see, this is a solid mass eating into the left kidney, only a thin margin of renal parenchyma. Here is also FDG avid necrotic mass eating into left kidney. This is solid mass, this is all necrosis. In case 9, there is involvement of pleura and lung also. So we reported this case 8 as probably lymphoma, and it came out to be high-grade lymphoma, that is DLBCL. But the case 9 we reported is probably this is tubercular because there is a lot of necrosis in all the lesions. So we gave one differential of tuberculosis, and finally it came out to be tuberculosis. So this is a of one of my friend, Dr. Sugandha, is sitting here. That is potential role of FDG PET in spinal tuberculosis, and what they conclude is it is a reliable marker for severe quantification of activity, correlates well with the clinical markers for response, imaging biomarker for non-invasive response evaluation, it can be done, and early detection of multi-drug resistance. So any tubercular pathology, if that is not going to respond to the ATT, that is multi-drug resistant, if we are doing a PET CT at an appropriate interval, then it is high likely chance that you will detect that multi-drug resistant at an appropriate time and decrease the morbidity. Another, as you all know, FDG has been taken up by infection, inflammation, and so inflammation, it can be septic inflammation, it can be aseptic inflammation. But FDG clearly doesn't differentiate between infective and aseptic inflammation. So to get the advantage of PET scan, what we do is we label FDG with WBC. As all the acute infection, they have migration of WBC cell. So we tag the FDG with WBC. So wherever there is one active infective focus, that will take up WBC, which is FDG labeled. So this is another head-to-head comparison of FDG labeled leukocyte versus FDG PET scan, which is better to detect active infection focus, done by my colleagues at FMRI Gurgaon. And what they conclude is FDG leukocyte PET has better sensitivity, specificity, accuracy, positive predictive value, negative predictive value than FDG PET for detecting occult infection, septic inflammation, and differentiating it from sterile inflammation. It is better for detection and evaluation of intra-abdominal. तो आप फिर पूछेंगे तो फिर हम किसमें FDG leukocyte कराएं और किसमें FDG कराएं. So the specific indication of FDG leukocyte may be intra-abdominal infection, renal infection, intracerebral, cardiac or orthopedic infection. Q, because in FDG uptake is physiological along the bowel loops. So any occult infection inside the small bowel or large bowel, that may be missed on FDG PET scan and may be taken up, may be shown in FDG level WBC scan. So these may be the indication. Now few images of FDG labeled WBC PET scan. what we did this orthopedic infection. Then patient is under evaluation for left hip joint osteoarthritis with associated infection as suggested by MRI. Scan reveals this is avascular necrosis. As you clearly see, there is no radiotracer uptake along the head of the left femur. So avascular necrosis of left femoral head with reactive osteoblastic activity and secondary degenerative changes, but no infection because there is no abnormal uptake. And the next scan here, as you can see, this is right knee, left knee, and the left knee is showing uptake of the WBC level with FDG, which is more than the contralateral side. So left knee joint intra and periarticular infection. The scan then help in the diagnosis of infection. This is a case, 45-year male, known case of CKD under evaluation for pyrexia of unknown origin. We did FDG labeled WBC scan and FDG both in this patient. And as you can see, this is FDG WBC PET scan and this is normal FDG PET scan. There are FDG avid mediastinal lymph nodes, more intensely is showing FDG uptake, but those lymph nodes are showing faint uptake of the labeled WBC. So, what was the final diagnosis is reactive mediastinal lymphadenitis on EBUS guided FNSC. Another case, again one CKD under evaluation of for FUO. We did both FDG labeled leukocyte scan plus FDG on two separate days. And as you can see, there is one atelectatic lesion in the left lung base which is not showing any FDG uptake, but that is showing uptake of the labeled WBC. So we suspected that this might be the focus of infection. CT guided biopsy was done and it came out to be mucormycosis. So take home message, FDG PET-CT is a helpful technique in diagnosis of occult infection, inflammation in both children and adults. It should become the routine procedure in the workup of FUO when diagnostic clues are absent. FDG PET-CT appears to be cost effective in routine imaging technique in infection of unknown origin by avoiding unnecessary investigation and reducing the duration of hospitalization. And FDG labeled leukocyte PET-CT is a promising technique demonstrating higher accuracy than FDG PET for detecting occult infection in some clinical scenarios. Thank you so much.
So what I understand is that when it's the question whether it's a malignancy or infection, we may not be able to differentiate. But as an independent for if we are suspecting inflammatory or infective condition, then we can, and we are in doubt that whether it is still existing or not, what is the location, then also it is useful.
Yes.
Thank you.
Suppose it's a case of PO and you get the FDG PET scan done and it comes out to be negative. What are the chances of being negative? And in case it is negative, what to do with that?
Sir, bloodborne infection are usually negative. I mean, FDG PET has to be positive only in such cases where there is one anatomical lesion.
So what to do in these cases? All investigations you have exhausted, FDG PET is also negative. So what did nature says about it?
That is crisis.
That is not PO.
Sir, it says that most of the cases they say
Then it is true PO.
Sir,
Then it is a true PO. Then you can say it is a truly PO.
but these cases usually settle of their own most of the time.
yes,
Sir, most of the time I have also seen in during evaluating such cases, when you stop all the medications, fever subsides.
आपका क्या ब्रांच है सर?
Surgery, sir.
सर्जरी तो आपके पास ही वापस भेजेंगे, देख लो जैसे करना है हम.
Right, sir. And then the clinical judgment, as sir was saying, clinical judgment is the best judgment. If FDG PET is negative.
Any other question?
पीयू में सर 45% पेशेंट्स जो हम डिटेक्ट करते हैं जो अभी तक लिटरेचर में है, मे बी स्लाइटली ये तो मतलब टॉकिंग अबाउट 2-3 ईयर बैक का कि अगर सपोज आप 100 पेशेंट हमें पीयू को भेजेंगे सो 25% ऑफ द पेशेंट वी विल टेल यू दिस इज द फोकस ऑफ द इन्फेक्शन. बाकी रेस्ट ऑफ द पेशेंट्स
Still, there is मतलब we need to maybe in future we will be able to do some more things in that. But as of now, if the PET-CT is positive, that is going to tell you this may be the cause for the infection. Otherwise
It is only 25%. It
Yes,
is only 25%.
25%.
Total.
But if patient has properly been worked and other investigation has been exhausted. अगर properly investigate नहीं किया तो 70% भी होता है हमारा.
So I'd like to provide my inputs. So see, in PO we are not looking at only infections. That's number one. We are also looking at malignancies. We are also looking at conditions like sarcoidosis and basically inflammatory conditions also. So in my personal experience, if you ask me, out of 100 PET scans that we must have done, like Snmi said, we find infections in about 25 to 30% patients. We also end up finding about 30% of cases which turn out to be, lymphoma, hematolymphoid malignancies. And another 10 to 15% which are neither infective nor malignant, but something like sarcoidosis. So overall, if you ask me what is the utility, in my personal experience, I would put the utility of PET scan, FDG PET scan, as somewhere around 70%. And speaking of infections, I would put it as around 30%.
So it means it should be one of the investigation in BO.
Yes, like if you remember the slides that I showed.
The recent edition of Harrison mentions FDG PET as an investigation in.
Okay, thanks.
I think with that we can close up now. We are already running an hour and a half late.
One question, yes, Dr. Man.
I just want to.
Is it neurologist in our?
I am an nephrologist. I will face PO in CKD and post-transplant settings. What would be your investigation of choice if it is leukocyte label FDG or without leukocyte in cases of PO with transplant or post-transplant settings?
Sir, what I am doing right now at my center is FDG level leukocyte.
Okay.
FDG level.
Thank you.
Because I have already shown one case that lung mucormycosis that was negative on FDG. If I can show you, that was negative on FDG, but yes, this one, CKD under evaluation of FUO, that lesion is negative on FDG but positive on FDG level leukocyte.
See, we have done a thesis on that also, but we have seen that FDG and leukocyte imaging are having the same result. So there is no added advantage in leukocyte imaging. And my point is that in leukocyte imaging, it will take entire day. 2 people have to be dedicated to that particular scan. So it is not easy to do that. So I will say FDG is a good answer to that. So if you people are suspecting, I think first go for the FDG. If the suspicion still persists, and then you have to visualize whether this patient needs leukocyte imaging or not. But first investigation in post-transplant patient, mostly they are having either infection or they may be having the lymphoma. So in that case, PET-CT will be the right imaging modality for that. That's what we do in this issue.
So
I'll
share my thoughts just to wind up. So as Dr. Swagat has shown, a very beautiful example is shown with FDG level leukocytes. But to answer your query, I think there is a certain level of evidence that we have to attain before we recommend a modality as a modality of choice. And in that sense, I think the literature on FDG is abundant. And yes, we do not find a diagnosis on FDG PET in patients in whom you are suspecting critically a lot many times. But as of date, I don't think there is enough evidence at hand to routinely recommend leukocyte centrifractory. So I would go with Dr. Snmi's opinion to send for FDG PET scans only. And then if it turns negative and if still you are harboring that query in your mind, then maybe as a second step modality it can be tried.
Thank you. Thank you everybody. If we move on to our next sessions now.
So this concludes our first session. I would like to thank all the chairpersons and the speakers for such a wonderful session, and everyone who's given insight into the topics discussed with precision and detail. Now carrying the program further, we will start with
We are really having a very good discussion, but I would request our speakers just to try to stick to the time. I know there's so many things to discuss, but I would request everyone to stick to time. Thank you so much. Thank you.
So now let's start with the second session, which is Thyroid diseases, nuclear medicine complementing endocrinologists and surgeons since 60 years. So for this session, I would like to call on stage our chairpersons, Dr. Rajesh Rajput, Head Department of Endocrinology, Gynox Hospital, Rohtak. He is a senior most endocrinologist in this region and a renowned personality. Dr. Satish Dharan, Senior Professor and Unit Head of Department of Surgery, PGIMS, Rohtak. Dr. Ashwini Sood, Professor, Department of Nuclear Medicine, PGIMR, Chandigarh. And Dr. Nilesh Agarwal, Professor and HOD, Department General Surgery, Kalpana Chawla Government Medical College, Karnal. And now I hand over this session to the chairpersons to conduct this session.
Good afternoon, everyone. Without wasting much time, let's start the session. The first lecture in this session is hyperthyroidism, approach of endocrinology. And for this, the lecture is given by Dr. Dia Boru. Dia?
Yes, thank you.
Thank you, sir. First of all, I would like to thank Dr. Praveen for giving me this opportunity. So as we know that thyroid is a very important area where coordination between endocrinologists and nuclear medicine is required. So my topic for discussion today is hyperthyroidism, approach of an endocrinologist. And I am DM endocrinology from AIIMS New Delhi and currently practicing as consultant endocrinology at Aadhar Hospital, Hisar. So I would like to first emphasize that there is a difference between the term thyrotoxicosis and hyperthyroidism. So these two terms are not interchangeable. Thyrotoxicosis is a state where there is excess thyroid hormone levels in blood. Whereas hyperthyroidism is a state where the thyroid gland is overfunctioning. Now the causes of thyrotoxicosis and hyperthyroidism are again different. So hyperthyroidism, that is primary hyperthyroidism where the thyroid gland is overfunctioning, the important causes are, the most common cause is Graves' disease, which is an autoimmune disease, followed by toxic multinuclear goiter, toxic adenoma or solitary functioning autonomous nodule, functioning thyroid carcinoma mets or activating mutation of the TSH receptor, and some rare diseases like McCune-Albright syndrome with activating mutation of GS alpha, struma ovary, which is an ovarian tumor causing again thyroid disease, and drugs like iodide excess leading to Joule-Bezos phenomenon. Then we have some other states like where there is thyrotoxicosis, where we have excess thyroid hormone levels in blood, but the gland is not overfunctioning. So the most common cause is thyroiditis, that is inflammation of the thyroid gland. Now thyroiditis can again be of different types like acute, subacute and chronic. Again silent thyroiditis also. And other causes of thyroid destruction like with certain drugs like amiodarone, radiation or infarction of an adenoma or ingestion of excess thyroid hormone which is known as thyrotoxicosis factitia. Then we have secondary hyperthyroidism where the disease is elsewhere other than the thyroid. So the most common cause is pituitary adenoma. It is TSH secreting pituitary adenoma. And lastly, gestational thyrotoxicosis. So I will now discuss Graves' disease. The history of Graves' disease dates back to the 18th century. The term Graves' disease is named after Dr. Robert James Graves, who was an Irish surgeon. And he did a lot of work on physical examination of patients, and he devoted also a lot of his life to how pulse should be measured and should be timed with the seconds hand of a watch. And Graves' disease is therefore named after this famous Irish surgeon, Dr. Robert James Graves. Now, Graves' disease accounts for 60 to 80% of thyrotoxicosis. It is more common in populations with high iodide intake, for example, the Japanese. Just like other autoimmune diseases, Graves' disease is again more common in females. The female to male ratio is 10:1, and age group is between 20 and 50 years, but some cases can occur even in the elderly and also in children. The pathogenesis of Graves' disease, there is a genetic component as well as there is some environmental factors. Now, there are certain genetic predisposing factors like polymorphisms in the genes such as CTLA4, TDPN22, or TSH receptor mutations, CD25, CD26. So, all these genetic polymorphisms may predispose an individual for Graves' disease. The concordance of monozygotic twins is 20 to 30%, whereas in dizygotic twins it is less than 5%. Then there are certain environmental factors which precipitate Graves' disease, like any kind of stress. Cigarette smoking is a major risk factor for Graves' orbitopathy rather than the onset of Graves' disease. Then immune reconstitution phase of HIV therapy or excess iodine. The antibodies in Graves' disease are known as antibodies. TSH receptor antigen is present not only in the thyroid gland but also in the orbital and dermal fibroblasts. So generally in case of Graves' disease, we tend to see a lot of Graves' orbitopathy and dermopathy because the antigen is present in the orbital and dermal fibroblasts as well. In addition, the other antibodies like anti-TPO and anti-TG antibodies, they are also present in 80% of patients with Graves' disease, but they are not pathogenic antibodies unlike TSH receptor antibodies. There are only a few indications where we need to measure TSH receptor antibodies. In pregnant patients with current or past history of Graves' disease to predict the occurrence of neonatal Graves, then to predict the recurrence of Graves' disease after drug withdrawal, and also in patients with unilateral exophthalmos to diagnose Graves' disease. These are the clinical manifestations of Graves' disease. Graves' disease, it can affect the excess thyroid hormone levels in the blood can affect the entire systems, starting from CNS. Patient may be exhibiting hyperactivity, irritability, impaired concentration, proximal myopathy without fasciculations, generalized hyperreflexia, hypokalemic periodic paralysis, which is more common in Asians, and fine tremors, which can be appreciated on outstretched hands. Cardiovascular manifestations also are myriad, like sinus tachycardia, atrial fibrillation, supraventricular tachycardia, white pulse pressure, palpitations, high output cardiac failure, and in patients with underlying CAD, there might be worsening of angina. In the GI, so most of these patients also end up with gastroenterologists because they have a lot of GI manifestations like diarrhea due to increased intestinal motility. Steatorrhea, although there can be present, and concomitant celiac disease. So celiac disease is another autoimmune disease which can be present along with Graves' disease. Pulmonary manifestations can also occur in the form of dyspnea. Skin manifestations are warm and moist skin, increased sweating, heat intolerance, palmar erythema, onycholysis, pruritus with diffuse hyperpigmentation. Here, there may be hair loss and the hair texture usually becomes fine. Alopecia can also occur in 40% of the patients. In the hematological manifestations, Graves' disease actually increased thrombotic state due to increase in the levels of thrombotic factors. Patients can also present with microcytic anemia and thrombocytopenia. In the reproductive system, females can present with oligomenorrhea, amenorrhea, decreased libido, infertility, and spontaneous abortions. Males can present with decreased libido and gynecomastia. The bone and musculoskeletal system is also affected. Patients can present osteopenia, osteoporosis, and fractures. Hypercalcemia can be present in 20% of the patients, and hypercalciuria is also common. So this is the classical triad of Graves' disease. The goiter in Graves' disease is usually soft, diffuse, and there is a bruit which can be appreciated on auscultation. However, in long-standing cases, nodular goiter can also be appreciated. Thyroid orbitopathy, it occurs in 25% of Graves' disease. However, orbitopathy can also be present even in the absence of Graves' disease. That can be seen in around 10% of the cases. Orbitopathy usually occurs concurrently or after diagnosis of Graves' disease in 75% of the cases, but sometimes it can precede the onset of Graves' disease as well. Orbitopathy is usually bilateral, but unilateral disease can also be present in 10%. Another component of the triad is thyroid dermopathy. Now coming to Graves' orbitopathy, while assessing Graves' orbitopathy, there is a score which is known as the clinical activity score that gives us an idea about the state of the activity of the Graves' orbitopathy. So this is known as the clinical activity score. There are 7 components. If the clinical activity score is equal to 3 or more than 3 out of 7, then this indicates active Graves' orbitopathy. These components are spontaneous retrobulbar pain, pain on attempted up gaze, down gaze or side gaze, redness of the eyelids, redness of the conjunctiva, swelling of the eyelids, inflammation of the caruncle or plica or both, and chemosis. So these are some of the examples of Graves' orbitopathy. As we can see, the patient on the left side is having clinically active Graves' orbitopathy. The score is more than 7, it is equal to 7 out of 7. He is having severe disease, and so urgent treatment is required in this patient. On the other hand, in the right side, we see a patient who is having a severe Graves' orbitopathy. However, his disease is stable. He is not having active features of inflammation. So he is having a moderate to severe exophthalmos, but the disease activity is not severe on his right side. These are again some examples of Graves' disease. The first one is a child, although Graves' disease is very rare in children, but this case I saw at my hospital. So this child was only 5 years old, and he presented to me with symptoms of thyrotoxicosis, and on evaluation he was found to have Graves' disease with Graves' orbitopathy. Luckily he is not having clinically active eye disease now. The one is again a female with Graves' disease, again having clinically active Graves' orbitopathy. The last one is a male who is having a huge goiter and symptoms of thyrotoxicosis, but his orbitopathy is not, he is not having any features of orbitopathy. Now, coming to the next component, that is thyroid dermopathy. So, thyroid dermopathy occurs in less than 5% of patients with Graves' disease and usually occurs concomitantly with moderate to severe orbitopathy. It follows Koebner's phenomenon, which means that lesions usually occur after trauma. Most common site is the anterior aspect of the lower limbs, presenting as pretibial myxedema. The lesion represents as a non-inflamed indurated plaque and it has got a pinkish to purplish orange hue. And nodular involvement may also occur, and sometimes it can even mimic elephantiasis. So these are some of the pictures of thyroid dermopathy where we can see non-pitting edema, and the pictures are almost resembling elephantiasis. And these are the nail changes. You can see plumber nails or onycholysis, which is separation of the nail from the nail bed, and something which is known as thyroid acropathy, which consists of clumping subperiosteal new bone formation. Okay, now coming to the lab evaluation of thyrotoxicosis. So how do we approach a patient when we are encountering thyrotoxicosis? So whenever you are encountering a patient who is having features of thyrotoxicosis, you should order some certain lab investigations. The most commonly ordered lab investigation is T4 and TSH. So every endocrine system, it follows a feedback pattern. So if T4 is elevated, the pituitary should produce less TSH. So TSH should be suppressed. So if T4 elevated and TSH is suppressed, then this indicates primary thyrotoxicosis. Now the patient is fitting into clinical diagnosis of Graves' disease, like he is having a soft diffuse goiter and there are features of orbitopathy and dermopathy, then you can be more or less sure that the patient is having Graves' disease. But if there is a diagnosis, if there is a doubt of diagnosis, then at that time you can order either radioactive iron uptake or technetium 99 thyroid scan. So this scan will give us an idea whether the patient is having diffuse uptake or nodular uptake, heterogeneous uptake or single uptake. So this will make the picture more clear. Okay, now if the T4 is elevated and T4 is normal and TSH is suppressed and T3 is elevated, then this is known as something which is known as T3 toxicosis. T3 toxicosis is rare, it occurs in only 2 to 5% of Graves' disease. And if T4 is elevated and T3 is also elevated and TSH is normal or increased, then this indicates the patient is having secondary hyperthyroidism. So here the lesion lies in the pituitary, so we should order an MRI of the pituitary to look for TSH secreting adenoma. These are the differential diagnoses of thyrotoxicosis. So in Graves' disease, as I mentioned, the patient will have soft diffuse goiter. There will be presence of orbitopathy. Dermopathy is very rare, so it may not be present. T3, T4 will be elevated and TSH will be suppressed. In radioactive iron uptake, there will be increased uptake, and on thyroid scan, we will get a diffuse uptake. Another is toxic multinodular goiter, where on palpation you will get a nodular type of goiter. The patient will not have features of orbitopathy or dermopathy, and on thyroid scan, there will be heterogeneous uptake. In the autonomous functioning thyroid nodule, patient will have a single nodular goiter, and on thyroid scan, you will get an uptake only in the single nodule, while the background activity will be suppressed. A common differential diagnosis of thyrotoxicosis is thyroiditis, which is inflammation of the thyroid gland. Thyroiditis has short duration, severe symptoms, sore throat, pain, and T3 to T4 ratio is less than 15:1. So these are the examples of thyroid scan. As we can see in the first one, the patient is having heterogeneous uptake with cold nodule. Whenever there is such presence of cold nodule, the risk of malignancy is 20%. So all cold nodules should be subjected to FNAC. In Graves' disease, again we are saying diffuse uptake. In toxic multinodular goiter, heterogeneous uptake. In autonomous functioning thyroid nodule, there is single uptake in one nodule, but the background activity is suppressed. And in thyroiditis, the entire gland is not showing any uptake. In clinical course of Graves' disease, 50% enter into remission, 50% do not. And patients may fluctuate between hypo and hyperthyroidism due to inhibiting and stimulating anti-TSH receptor antibodies. Antithyroid drugs are the treatment of choice for Graves' disease, and patients who do not go into remission, definitive treatment with either radioiodine ablation or thyroidectomy should be done. And monitoring is done with T4, T3 and not with TSH, because TSH may remain suppressed for a very long time due to suppression of the pituitary thyroid drops. The commonly used antithyroid drugs are propylthiouracil, carbimazole and methimazole, which inhibit the hormone thyroid peroxidase, and they also enhance spontaneous rates of remission. PTU is not a commonly used drug because it is highly hepatotoxic and causes fulminant hepatic necrosis. The only indication of PTU is either first trimester of pregnancy or thyrotoxic crisis. Methimazole and carbimazole usually is given in doses of 30 or 40 mg in divided doses. They are commonly used drugs of choice in hyperthyroidism due to Graves' disease. Methimazole and carbimazole should be avoided in the first trimester of pregnancy because of teratogenicity associated with it, which is fetal aplasia or quadral atresia.
Here, can you wind up now?
Yes. So I would just like to, I will not cover all these things. So I would just like to conclude and tell you the take-home message is that hyperthyroidism means overfunctioning of the thyroid gland, and commonest cause is Graves' disease followed by toxic multinodular goiter and autonomous functioning thyroid nodule. Graves' disease is usually a clinical diagnosis. In cases of doubt, always do a technetium 99 thyroid scan. Management includes antithyroid drugs for 18 to 20 months followed by definitive treatment. In toxic MLG or AFDTM, radioactive iodine ablation is the preferred therapy subsequent to thyroid drugs.
Thank you, Riya, for nicely giving an overview of hyperthyroidism. Now, just for the benefit of all of us, there are three modalities of treatment: antithyroid drug, radiotherapy, and surgery. And it's always a question among general physicians, which therapy is to be given to which patient of hyperthyroidism. So, as an endocrinologist, just briefly tell us when you are going to choose radiotherapy, when you are going to choose drugs, and when you are going to refer your patient for a surgical. Because all three specialty people are sitting here.
In any case of hyperthyroidism for Graves' disease, the first line of treatment is antithyroid drugs. Antithyroid drugs commonly used are methimazole or carbimazole. We need to give antithyroid drugs for a duration of minimum 18 to 24 months. After giving that, 50% of the patients go into remission and 50% do not. Those patients who do not go into remission need definitive treatment in the form of either radioiodine ablation or surgery. Surgery is preferred in cases where there are huge goiters which are not likely to go into remission after radioiodine ablation. Or if the patient is having severe Graves' orbitopathy, because with iodine therapy there might be worsening of orbitopathy. These are the indications for surgery. Otherwise, in other cases, those patients who are not going into remission and have small to moderate sized goiters who are not having active orbitopathy, in those patients, radioiodine ablation is the preferred mode of treatment.
In current era, why not?
In current era, there are two schools of thought. Why not straight away send the patient to radiotherapy? Why you want to give a trial for 18 months to drug? Because there is a Japanese school, there is an American school, there is always a controversy going on. But definitely in current era, with increasing availability of nuclear medicine centers, large number of patients can be offered right at day one radiotherapy because with radiotherapy also there is almost equivalent chance of cure of the disease. And then patient may not need to take drug for 18 months or 2 years, and large number of them actually need lifelong therapy. So that is a dilemma. So why not to take up radiotherapy? And next, children's hyperthyroidism in children is a big issue.
Yes.
So what is your take on advising radiotherapy in a hyperthyroid child?
So in children, again, as you have mentioned, there is a lot of dilemmas. So although the risk of malignancy is very, very rare, but still there is a theoretical risk. So some schools say that it is better to continue with antithyroid drugs till at least 20 years, till the child becomes an adult.
So we will open the session for one or two brief comments. With comment now, currently it is recommended that after 10 years of age, even children with hyperthyroidism can safely be given radiotherapy for treatment of hyperthyroidism. Less than 10 years, I think there is not a robust data, but more than 10 years, I think it is safe, can be given. Large number of us are practicing using nuclear medicine, taking help of our colleagues for treatment of hyperthyroidism, even in children. And there is data which is well published that in children, even the use of drugs for prolonged period of time is also associated with malignancy in long term. So it is not nuclear medicine or giving a small dose of radioiodine which is causing malignancy. So there are some issues, but currently guidelines are there that more than 10 years we can use. So there are one or two small comments or questions were invited.
Yes, yeah, actually, you rightly mentioned that there are two schools of thought. In European guidelines, they give 12 months of antithyroid drug, and in American guidelines, they directly say go to the radioactive therapy. So actually, here in AIMS, we are following 12 months. I think here used to follow 12 months and all. In 12 months, because the patient come to endocrinologist, so they are जिसकी लाठी उसकी भैंस हो जाती है. So nuclear
नहीं ऐसा नहीं है. अभी endocrinologist हो. We send lot of patients for radio ablation. It all depends on availability. And in private setups, the cost of radio ablation is somewhere close to 15 to 20,000. Good number of patients cannot afford that cost. When it is sending them to institutes, getting up a date, standing in queues, that becomes a very big issue. So those are some of the issues. Otherwise, there are two schools of thought, and such type of controversies can never be sorted out because people have their own ways of thinking.
सर मैं भूल गया तो मुझे बोलना नहीं चाहिए था ये नहीं एक्चुअली क्या सर कि आप रेडियोएक्टिव थेरेपी जो है एज यू ऑलरेडी मेंशन दैट कैन बी गिवन एट कॉस्ट सो इसमें जो थ्योरेटिकल ऑन्कोजेनिक कंसेप्ट है वो भी एक्चुअली
वो गलत है.
हाँ वो गलत है और 10 ईयर से ऊपर तो आपने बोल दिया ऑलरेडी कि इजीली कैन बी गिवन 10 से नीचे इसलिए रख रहे हैं कि वो भी हम ऐसे प्रिवेंशन
ग्रोइंग एज है, माइटोजेनेसिस हो रही है, हमें पता नहीं है, तो उस एज में हम उस पे रहते हैं. Otherwise, after 10 years, there are no guidelines. So, if there are any questions from our young colleagues,
so just a small point to make. As you said, the radioactive iodine cost is around 30 to 40,000, but I think
no, not 30 to 40,000.
It's very
15,000 rupees. Yeah.
So even it's 5,000 rupees in our center.
चलो
Thank you so much, sir. Thank you.
Right.
That
So
is
we are-
like coming from endocrinologist.
अभी हम शॉर्ट चल रहे हैं और
Yes, sir. The biggest proponent for radioiodine is endocrinologist. So that is, I think, the biggest thing we can get as a nuclear medicine fraternity. Thank you so much.
So
sir.
thank you.
sir.
We will move on to the next lecture, and I will request my nuclear medicine colleague to invite the speaker for next lecture. We are running short of time. All those are here, so you can continue your discussions during lunch and rest of the time.
We have session.
Good afternoon. So I'll invite Dr. Abhishek Kumar. He's from IGMC Shikla. He's practicing for a long time and he'll be talking about the role of nuclear medicine.
My topic is nuclear medicine in benign thyroid, so I won't take much of time. So the topic I'm talking about today is nuclear medicine in benign thyroid diseases. So I won't take much of time and won't dwell into the details of anatomy and physiology of thyroid. But here it is a figure that denotes the iodine metabolism in thyroid disease. I
iodine metabolism in thyroid, and we see that thyroid cells preferentially accumulate and trap iodine and incorporate it into hormones, which are then sent into blood. So iodine forms a very integral part of the functioning of thyroid gland, and as an essential component of its hormones. Thyroid tissue exhibit unique property of iodine trapping and its organification. So the nuclear medicine techniques provides us with this unique ability to visualize this characteristic of thyroid tissue, and it has diagnostic as well as therapeutic implications. Similarly, the radiopharmaceuticals used in the context of nuclear medicine benign thyroid disease are the radioisotopes of iodine, iodine 131, and technetium permanganate. That is also trapped, the similar mechanism as that of iodine through the sodium iodide water, and but it is not organified, so it is called pseudoiodine. The technetium 99 and iodine 123 have good imaging characteristics and are mostly used in diagnostic applications, whereas the iodine 131 is a beta metal and is used for therapy of benign thyroid. Coming to the diagnostic aspects of nuclear medicine in benign thyroid diseases, so we have already heard from the previous speaker about thyroid toxicosis. They are the common causes of thyroid toxicosis: Graves' disease, subacute thyroiditis, toxic multinodular goiter, toxic adenoma, and also many others. The therapy of these diseases is different, and so their differential is very, very important. The most common procedure of nuclear medicine done in these situations is thyroid scintigraphy or thyroid scan. So the scintigraphic patterns of different causes of thyroid toxicosis are different and are unique to the underlying pathology. Thus, thyroid scintigraphy is helpful in differential diagnosis. But it is very important that scintigraphic images are interpreted in light of the latest biochemical GFTs, clinical history, and examination of the patient. The tracers again used for scintigraphy are technetium 99 and iodine 123. The benefit of technetium 99 is that it is widely available, it's cheap, and the imaging is done only in, at 20 minutes. This slide shows the thyroid scan, normal appearance of a thyroid scan on scintigraphy. We can see that we can visualize a butterfly-shaped gland on both, and we can see both the lobes of the thyroid that show fairly homogeneous trace uptake, and the isthmus can be visualized sometimes, but other times it cannot be. And there is apparently a little increased uptake towards the center of the gland. In the medial aspect, it is due to the thickness of the gland. We can also visualize the slimy glands of the both sides. This slide represents thyroid scan in the patient of Graves' disease who presented with goiter and toxic symptoms. The T3, T4 was raised and the T-search was suppressed. We can see that both the thyroid glands overall is enlarged, and both lobes show increased homogeneously increased trace uptake in both the lobes. The background tracer activity is significantly suppressed, and we are not able to clearly visualize the slimy glands. So the findings, the scan findings suggest a diagnosis of Graves' disease, keeping in mind the EFTs in correlation. This type of scintigraphic findings are found in subacute thyroiditis or destructive thyroiditis. Here the patient presented with thyrotoxic symptoms, and we can see that no definite discernible activity is noted in the thyroid gland. There is significantly increased background tracer activity in the blood vessels, and also salivary gland physiological tracer uptake is noted in the salivary glands. Here we had a patient who underwent thyroid scan for goiter with thyrotoxic symptoms, and we can see that the tracer activity is increased in both lobes of the thyroid, but it is inhomogeneous. Somewhere it is increased and somewhere it is decreased. Overall, there was increase in activity, and the salivary glands are also faintly visualized, and these scan findings are suggestive of toxic multinodular goiter. Again, in the next patient, the patient presented with right-sided neck swelling and thyrotoxic symptoms. On thyroid scan, focally increased tracer uptake was noted in the region of the right lobe of the thyroid, and the rest of the gland was not visualized. Background tracer activity as well as the salivary uptake was faintly, very much suppressed and faintly visualized. So this slide shows the thyroid scan in toxic adenoma. So this is how we can differentiate between various different differentials of thyrotoxicosis or thyroid scintigraphy. Now coming on to amiodarone-induced thyrotoxicosis. Amiodarone is a class 3 antiarrhythmic drug. It contains a significant amount of iodine, and incidence of thyroid dysfunction in its usage is around 2 to 24%, with 1 to 10% of the patients having hyperthyroidism. It can be of two types, type 1 and type 2. So type 1 is iodine-induced hormone synthesis and release. Type 2 is due to destructive thyroid. In these cases, radioactive iodine or technetium for technate scan will not be able to differentiate reliably between type 1 and type 2 or amiodarone-induced thyrotoxicosis. And here, technetium maintenance system can be used, in which the type 1 will show preserved tracer uptake, and type 2 there will be reduced or absent tracer uptake. Apart from scintigraphy, we can also do thyroid uptake with radioiodine, both the tracers iodine 131 and 123. However, it is not as commonly used as scintigraphy, and main use is in calculation of therapy dose in patients of Graves' disease. Similarly, technetium 99 per technate uptake is also done. It is normally done as a routine part of scintigraphy in the same setting, and normal values are 0.3 to 4.5. Advantages are it is done within 20 to 30 minutes, but it is of lower accuracy than radioiodine uptake, and it is not reliable for therapy dose calculation because of the lack of organization of technetium 99. Moving on to hypothyroidism, nuclear medicine has a very limited role in hypothyroidism, and indications are mainly evaluation of congenital hypothyroidism. And by thyroid scintigraphy, we can by thyroid scintigraphy in thyroid agencies or localization of ectopic thyroid, or by percolated discharge testing the defects in intrathyroidal organization of thyroid. This is a thyroid scan of a child who presented with congenital hypothyroidism, and we can see that no definite tracer uptake is noted in the region of the thyroid bed or elsewhere, and physiological uptake is noted in the salivary glands, and there is mild activity in the vaginal blood too. Again, this patient was referred for thyroid scan due to midline neck swelling. The TFTs were normal, and on scan we can see that there is a flame-shaped midline tracer uptake that is fairly homogeneous, and there are no cold areas. The salivary glands were also visualized, and it was diagnosed as linear ectopic thyroid. Again, this slide shows the thyroid scan then in a child with congenital hypothyroidism. The KSH was raised, and all ultrasonography thyroid was not visible. On thyroid scan, there was no activity in the region of the thyroid bed. However, a focal uptake was seen in the region of the mouth, which on lateral imaging was noted in the base of the tongue. So the diagnosis of lingual thyroid was supported. Coming to thyroid nodules, there are lesions in the thyroid that are radiologically different from the surrounding thyroid parenchyma, and it is very important to characterize these thyroid nodules to ascertain the risk of malignancy and plan further management. Usually, ultrasonography and fine region aspiration based on the suspicious ultrasonographic features is done for such nodules. Thyroid scintigraphy essentially is a map of functioning thyroid parenchyma, and it tells us about the functional status of thyroid nodule. So if nodules are hot or warm, they are rarely malignant, and so financial aspiration is not indicated in these nodules. The cold nodules need further ultrasonographic evaluation by scoring systems such as TRADS and financial aspiration if indicated. Indeterminate nodules are nodules that are radiologically visible, but on thyroid scan they are not seen, and they have same significance as cold nodules and should be followed up like cold nodules only. These spotted nodules are nodules that are hot on technetium 99, but they are cold on iodine 123 scan, and they require further evaluation because they are approximately 20% chance of malignancy. It is hypothesized that some of the malignancies of thyroid, they lose their organification functions, but the trapping functions are maintained. So this is the reason for the discordant nodules. So overall, in areas of with sufficient iodine uptake, the thyroid scan for nodules is indicated if PSH is suppressed. However, in areas of iodine deficiency, all the patients of multinodal goiter should be subjected to thyroid scans. PSH is not alone sufficient to exclude autonomously functioning thyroid nodules. Further, on PET-CT, any metabolically active thyroid incidentalomas greater than 1 centimeter should undergo FNA because there is high risk of malignancy. This is a thyroid scan of a patient showing a cold photogenic or a cold defect in the region of the middle one-third and overall lower two-third of the right lobe of the thyroid. Otherwise, fairly homogeneous space uptake is noted in the rest of the right and the left lobe of the thyroid. Physiological uptake is also noted in the parietal salivary gland. Here, there is in this scan, thyroid scan, there is focally increased uptake, tracer uptake in the upper half of the left lobe of the thyroid, and there is mildly suppressed tracer activity in the rest of the thyroid gland. The salivary glands are also faintly visualized. So this is an example of a hot nodule. And this is a thyroid scan of a patient in multinodular goiter. We can see that there are multiple areas of increased and some of decreased tracer uptake, and some are cold areas as well. So this is an example of thyroid scan in a nodular goiter.
One more minute.
So this is a cold nodule in Graves' disease, and moving to therapy. Once the diagnosis of primary hyperthyroidism is established, so initial modalities are radioiodine therapy, antithyroid drugs, and surgery. And RI therapy is done with iodine 131. It is a beta emitter, and the beta particles cause cellular apoptosis and destruction of thyroid follicles, and finally the replacement with fibrous tissue. Situations that favor giving RAIR, patient preference, if they are comfortable with hyperthyroidism for the rest of their life and they require immediate cure of hyperthyroidism, and otherwise patients who are unresponsive or intolerant to ATDs or increased surgical risk due to comorbidities and other factors, or women planning pregnancy in future, that is more than 6 months after therapy. In multinodular goiter and toxic adenoma, the situation that favor RAI is patient preference again, whether they want to avoid surgery and get a chance to achieve euthyroidism, and advanced age, increased surgical risk, small goiter, sufficient radioiodine uptake in the nodule or the nodules. Contraindications are pregnancy and lactation are absolute contraindications, and if the patient is unable to comply with radiation safety precautions, if there is coexisting or suspected thyroid cancer, it has to be first evaluated. And pregnancy planned within 6 months, uncontrolled hyperthyroidism, severe raised ophthalmopathy, especially in smokers, and prerequisites we have to take detailed medical history. We have to confirm hyperthyroidism with recent EFTs, thyroid scintigraphy or radioiodine uptake, ultrasonography thyroid, negative pregnancy test, preferably within 24 hours of giving the therapy, and FNA of any suspicious nodules that are found on investigation. In case of breastfeeding women, it is prudent to delay the therapy until the nursing is stopped and the lactation ceases for at least 6 weeks to protect the breast from radiation. In patient preparation, the aim is to optimize the concentration of iodine in hyperfunctioning thyroid parenchyma. So ATD should be withdrawn at least 3 days before therapy. Radioiodine, if is used as first-line therapy, we can consider pre-treatment with ATD to deplete the thyroidal hormone stores. And discontinuation of iodine-containing medications should be done approximately 2-3 weeks prior to therapy. And in case of amiodarone, may be required for months. Low iodine diet and different dose calculations for iodine 131 have 2 approaches. Either a empirical fixed dose in the range of 10 to 15 milligrams based on the degree of hyperthyroidism and the rough estimate of the gland size. The other is the calculated dose that is based on the base disease to achieve a hypothyroid status, whereas in toxic multinodular goiter and toxic adenoma is to achieve a euthyroid status. So the patient should be followed clinically biochemically for after 1 to 2 months, and then for 4 to 6 weeks weekly till 6 months, or if the patient is rendered hypothyroid. Retreatment is possible after if the hyperthyroidism persists beyond 6 months. I'm skipping these side effects, common. It can also be used in non-toxic nodular goiters if the patient is not fit for surgery and other minimally invasive tissue ablation techniques due to age or surgical comorbidity. And it can decrease the goiter size by 30 to 40% in 1 year, especially used in combination with the recombinant TSH. So in conclusion, nuclear medicine plays an important role in thyroid therapy and thyroidnostics of thyroid, hyperthyroidism, and has a well-established and essential role in a variety of benign thyroid conditions. Thank you.
Thank you very much, Dr. Abhishek, for the nice and simple presentation. The house is open for any comments or questions, please.
I would just like to make two comments. One is that iodine 123 is not used in India, so we are using iodine 131 only. This is for the audience. And the second comment is that the RAU values that you showed are largely the RAU values that we have used for a very long time. But we must remember these were RAU values that were established by one paper done from the Department of Community Medicine at AIIMS, published in 1976, which was the era of iodine insufficiency. After 1989, since the universal iodization program was implemented and iodine sufficiency has been achieved, so we have reassessed this normal range of RAIU, and our HOD at AIIMS has himself done this study. And the new values that we now follow are 3 to 7% at 2 hours and 8 to 18% at 24 hours. Yeah, so this was a paper titled Re-establishment of RAIU Values, published in the Indian Journal of Medical Research, which is an ICMR publication. So these are the points.
I would like to ask you, still you go for a 24-hour uptake or 2 hours uptake is sufficient for deciding the dose?
So we go for a 24-hour uptake. The reason being, there is an entity called as rapidly discharging glands in Graves' disease. So when the 24-hour uptake is lesser than the 2-hour uptake, we call it as a rapidly discharging gland. And the implication is that a rapidly discharging gland will not allow sufficient residence time for the iodine within the thyroid. So the effective half-life of iodine 131 in these glands is very low, which means that I'm looking at a possible therapeutic failure. So it's
Apart from one, I would like to ask from endocrinologist colleagues also and from nuclear medicine from Dr. Snmi Nc. Do you encounter unilateral grave disease, something like that? We have encountered in our setup and diagnosis. And how do you explain that?
So I have read about 2 cases and seen one in 18 years.
Any comments from endocrinologists?
Well, highly uncommon. It may be disease in evolution, and again, more learning is needed that why it is limited only to one lobe of the thyroid and other lobe is not functioning.
Actually, we have seen around 15 to 20. Any comments from Dr.
Yes, this is entirety we see actually. As Dr. Damle ne bola, it is very rare, but we have seen cases with this, and I think we can treat it like a grave disease. Nothing to
Two important comments and questions before we finish. Because most of the time in routine practice, technetium uptake is done. Even not 131 uptake is done for routine benign disease. So based on technetium uptake, for all of us, what is the normal uptake value on technetium? To say that this is a normal uptake, this is going towards hyperthyroidism. Question number 2. Just a small comment. You said that the aim of treatment of Graves' disease is to produce hypothyroidism. I disagree. Aim is actually to produce euthyroidism, but unfortunately we end up in producing hypothyroidism because when we give radiotherapy, large number by 10 years, more than 50% will become hypothyroid. So aim is actually to produce euthyroidism, but we end up producing hypothyroidism. So the answer for first comment, and then we wind up this session.
So technician 99 uptake is usually 0.3 to 4.5, what we take as normal. And anything above 4.5 is increased and below 0.3 is decreased. But we have to also see the other things that like the slightly gland uptake and other things with that. As such, technician uptake should not, most of the use of uptake is for calculation of the therapy dose, if we are calculating that. It is not reliable for calculation of therapy dose because again, like it's not organified, so it won't tell you about that. Second thing, sir, in Graves' disease, sir, the basic problem is thyroid receptor antibodies. So if we try to achieve euthyroidism, so we are going to keep some amount of gland there, viable cells there, but we are not treating the antibodies. They will still be there. They will again stimulate and chances of treatment relapse.
So we will discuss that issue again. That's a controversial issue regarding thyroid receptor antibody. Also, role of drugs. Even on drug therapy, there is reduction in level of thyroid receptor antibody, and there are different types of thyroid receptor antibody. Currently, again, routinely not measured. So these are controversial issues. We will discuss later on. We'll wind up this session. We are running late, and now we invite Dr. Satish to advise our next.
One thing.
Okay, last question. Last question, Dr. Parvaz.
See, it means, it appears that the best treatment is surgery. From all things, we'll get rid of the antibody, everything. Number one, your comment about this. Number two, it means we are underutilizing the role of radioactive iodine.
I agree with you. We are underutilizing radiotherapy in management of Graves' disease. There is no doubt about it. Currently, surgery is the last form of therapy. It is not the first form of therapy.
Sir,
So,
why
when we
last?
wind up this session, sir, we will continue that.
Okay,
we are basically running very short of time. We are trying to catch up with time. So I request Dr. Sanjeev Pasar, he will talk about the malignant thyroid disease. He is a senior professor and head surgical oncology at PGMS Rohtak. And I hope that Dr. Sanjeev will stick to the time.
ये सर्जरी में टाइम में स्टिक नहीं रहता तो क्या रहेगा?
So at the outset, I want to thank the organizers for giving me this opportunity, Dr. Kundu and team, Dr. Vasa for giving me this opportunity. And in a meeting like this, I think the role of surgeon is to set a stage from where my nuclear medicine colleagues can actually take up, because we are concerned about how nuclear medicine people are going to take this malignancy once we have operated these patients. So thyroid cancer is, there are two types of malignancies. Basically, we talk about differentiated thyroid cancer and medullary carcinoma, which we are basically thinking. Anaplastic malignancies. So anaplastic malignancies will not have much of a nuclear medicine role. This can be sporadic or genetic. You all know incident is rising with passage of time. They say incidence is rising, but it is probably because of the ultrasound detection of lesions which were not going to be presenting otherwise when we are picking up them early. So what are the treatments? Let's straight away come to this thing. What is the treatment for thyroid malignancy? One, except for one thing, which is an active surveillance in very few cases. Rest all need some intervention. Primary intervention most of the times is surgery, and then nuclear medicine, radiotherapy and systemic therapy. Every has got a definite role. And how we treat this is by risk stratification and optimize treatment to every individual so that we do not over-treat, so that we do not under-treat. And there are various risk stratification models. AJCC, they said that risk stratification is to be done, and that was the AGs, MEs, MESIs, all those criteria were there, which were saying that risk of death, how much is the risk of death in a particular stage. But then ATA came up with this thing that it has to be, once you have given the treatment, after this, still there is a risk assessment required, because the risk of persistent disease, the risk of recurrent disease, how much it is, and how the disease is responding to the given treatment. With passage of time, differentiated thyroid cancer is going to come up and again becoming, say, anaplastic malignancy. Initially, which was iodine avid, is now going to become iodine non-avid. So how you are going to treat those cases? So that means you have to do a dynamic risk stratification rather than a clear-cut written, say, on day one you can't decide it. It has to evolve with passage of time. So I'll take this from a very basic lecture. Very basic, I can't call it a lecture, very basic thoughts. How we start. Patient comes to us with thyroid nodule. First thing we do is a TSH, and if TSH is, we exclude, basically we are trying to exclude the patients of hyperthyroidism. Once they are separated, so euthyroid and hypothyroid patients, we are going to treat them. So first investigation that we order as a surgeon is the sonography. And with sonography, what we are looking at. For sonography, we want to know about the thyroid. Where is the nodule? Is this single nodule or are there multiple nodules? What are the features of this nodule, which is based on the certain radiological ultrasound features, which will suggest whether it's a malignant nodule or it's a benign nodule. But it will only suggest, it will not be defining. And then we also want to look at the lymph nodes. That are there lymph nodes present? Are they really involved? Which level they are actually involved? Once we have done this ultrasonography, next thing we order is an FL. And based on these two things, most of the time we are certain how we are going to proceed further. So this is what the TINETS thing tells, that is the ultrasound-based on the ultrasound we can, where various techniques, say
characteristic features of thyroid, what is the composition, how much is the equation, various things have been given and there are various, numbers have been given to this, and we can label based on various points, we can label what is this, which is thyroid 1 or thyroid 5. And this makes it, this is the, how much is the percentage likelihood of malignancy. So thyroid 3 will again have 5 to 10% of malignancy. Thyroid 1 and 2, generally these are patients that we will not do much. From here the controversy starts, what is to be done and how much surgery is to be done, how we have to proceed in the future. But thyroid is just imaging, it is just a shadow, what we are seeing. We have to prove it actually with the cytology. So the next thing comes the FNA, and FNA, what we get is a Bethesda system of reporting the cytology. Here we are very clear up to, there are 6 categories on this, and out of these 6 categories, 1 and 2 we are not much bothered. 1 we have to repeat 2-3 times, and up to this the risk of malignancy is also very less. But still, even if we have reported benign, there is still up to 3% risk of malignancy is there. The problem starts here. And 5 and 6, here we have decided that this patient is having malignancy and we are going to treat it like malignancy. But these are the patients which are in between. And here comes the role of molecular studies. We have got a 7-gene panel, we have got various important genes which are related to a gene defects, which are related to a particular type of malignancy. We can aspirate from the lesion, washing and study these genetic abnormalities. And we have been talking about, say, PET-CT. PET-CT is indicated for so many malignancies. Is it indicated in diagnosing a case of CA thyroid also? So that I think my nuclear medicine colleague will tell. So once the few slides on this, what is a high clinical index? If there is a, this is basically based on history and certain examination factors. If there is a rapid growth of a nodule, imaging feature, that is based on the thyroids, they are also suggesting it to be thyroid 4, 5, and physical examination we have done, age is on a higher side, say more than 55 years now, there is history of radiation, there is a family history, these are the patients, whatsoever may be the lesion size, whatever, but they are in high clinical index of it being a malignant lesion. And there are certain ultrasound features, I think this we have discussed of a node, so if there are nodes, if there are enlarged nodes, there is loss of fatty hilum, rounded shape, hyperechogenic, peripheral vascularity, all those things tell that these nodes are malignant. So till now what we have done is that we have seen a patient with thyroid nodule and we have done an ultrasound and we have done an FNC and reached certain conclusion. Now comes the surgical decision in these patients. Surgical decision is by and large very crystal clear most of the time. We have got actually 3 things. What we can do is, simplest thing is we can do a lobectomy and isthmusectomy. Next will be a total thyroidectomy. Next will be lymph node dissection, whether to do it or not, how much lymph node dissection is to be done. So again, just summing up, preoperative staging we have done with ultrasound. There is one thing, cross-sectional imaging. Do we actually need it? Because thyroid is like right in front of you, you have clinically seen it, but still we need cross-sectional imaging, CT with contrast. There was some controversies previously that contrast should not be used, but now I think this is settled because this iodine which is given here does not interfere with the later on radioiodine therapy because there is a 6 to 8 weeks time before you actually take up the patient, and by that time it will not affect. And cross-sectional imaging is required to know once the nodule is situated more posteriorly, it is more close to the trachea. And on those areas where we think clinically that it is going to be difficult to resect, we do a cross-sectional imaging. It will also tell us where is the nodule situated, is it having a tissue around it, a normal thyroid tissue around it, so that we can decide whether it's an intrathyroidal disease or an extrathyroidal disease. CT chest, which we routinely, these days we always ask for CT chest and abdomen, most of the malignancies, but in thyroid we routinely do not advocate CT chest. But it is done in clinically locally advanced disease, where there is a dysphagia, there is hemoptysis, voice change, fixed mass, then obviously we go for CT chest. Otherwise, as a routine, we do not go for CT chest. And routine preoperative FDG PET for diagnosing malignancy is not indicated. So here we can take a break. Now we are just having, these are the preoperative staging we have done. Now what we have to see, what are the results, now do we proceed further. So there was Bethesda 3 and 4. This is the lesion which are in between. So if there is high clinical suspicion, which I have already discussed, if there is a high clinical suspicion in Bethesda 3 and 4, and there is a low clinical suspicion in Bethesda 3 and 4. If there is a high clinical suspicion, we don't have to do anything further. We have to straight away go for lobectomy at least. And maybe in certain cases, we go for thyroidectomy straight away. But most of the times, it is the lobectomy which will further confirm what it is. And if there is a low clinical suspicion, none of these things are present, then the role of molecular diagnostics comes, because molecular diagnostics will definitely tell in certain genes like BRAF mutation, if it is seen, 84% chances of being malignant. So then we are very sure that yes, it is malignant, so we should straight away go ahead for surgical intervention. And if molecular diagnostics, they actually independently, individually do not guide us, but they will become a part in a whole scenario. Then these patients, if molecular diagnostics are negative, there is low clinical suspicion, then you can even go for nodule surveillance. The lesion nodule size is less than 1 centimeter. You may not operate and keep patient on annual surveillance with ultrasound. So this is something about molecular studies. Negative gene panel, if it is negative, then only 14% risk. But if BRAF is positive, then up to 95% of the patients are malignant, and we straight away go for surgical. Then comes the Bethesda 5 and Bethesda 6, which are suspicious of malignancy or malignancy. So these patients, this is very interesting that in this group also, if there is small lesion less than 1 centimeter size, these are the patients where we can choose to do only surveillance. In certain, I'll come to this later on also, certain group of patients which are high risk patients for surgery, which are elderly people, small lesion, no other high risk features, no lymph nodes, no multicentric disease, then we can keep them for surveillance. Otherwise, all these patients will need some surgical intervention. Now, some surgical intervention means either lobectomy, or we are going to go ahead with total thyroidectomy and therapeutic neck dissection. So, if the lesion is more than 1 centimeter, then we will assess for nodal disease on ultrasound, we will assess for local extent or CT scan, and based on this we will decide whether we are going for lobectomy or we are going for total thyroidectomy.
Dr. Sanjeev,
so
please try to write.
2 minutes. So these are the patients where we are going to go ahead for total thyroidectomy and therapeutic neck dissection. Neck dissection is very important, that neck dissection has to be done therapeutic neck dissection. That means only if the nodes are clinically positive or you are able to aspirate the node, guided aspiration, and you can prove that this node is malignant. Otherwise, elective or prophylactic neck dissection has no role in differentiated thyroid cancer. This is not true for medullary carcinoma thyroid. So, I think, and this is always followed up with something. So, therapeutic neck dissection, and we think there is no residual disease left now. Being a surgeon, we are thinking everything I have taken out. Then I have to send this patient for RA therapy for my colleague of nuclear medicine to decide whether this patient actually requires RA therapy or not. And there is a definite protocol where they will decide whether it is required or not. There might be a situation where there is a gross residual disease left, and then these are the patients, gross residual disease is either local or maybe a distant metastasis. So these are the patients which will be further studied. These now patients which are unresectable, and I have done my job. So now these are the patients who will go to the radiology or nuclear medicine. People who will decide what is to be done with these patients. And they can be ablated. TSH suppression is always required in differentiated thyroid in all type of malignancies of thyroid, but suppression is required for basically differentiated thyroid cancer and LCA. And EBRT, IMRT systemic therapies are there. So, thyroidectomy and nodal dissection. After this, there are various. These are the basically questions. Once I have referred a patient for radioiodine, what I want to know is what is the dosage, how many days following thyroidectomy they will take up the patient, thyroid hormone, is it required, or we can just give a recombined TSH, TSH suppression, how much TSH suppression is to be done later on, and how to follow up these patients. And then comes the recurrent or metastatic patients, which are further treated with various modalities, radioiodine therapy for iodine avid, non-avid patients, There is some role of high dose radioiodine therapy in non-AVID patients also, which I think my colleague will be discussing. And then there are systemic therapies, various types of kinase inhibitors, or we have got PD-1 inhibitors, which can be used. So same thing is, I will just take up 1 or 2 more minutes. For medullary carcinoma thyroids, it's a different ball game. Surgery is the mainstay. We don't have radioiodine treatment facility here. It is not going to be only thing what we can do is surgery. Extensive preoperative workup is required because it may be a part of a syndromic presentation. So we want to know calcitonin, CEA, calcium, and few chromocytoma workup, and then screening for that oncogene because we might be telling about the prophylactic thyroidectomies for children in that family. And we have got CT, neck, chest, and abdomen, everything we want to look, and we have 68 CT also. And based on this, only treatment is for very small lesions, total thyroidectomy with central node dissection, bigger things, total thyroidectomy with complete dissection, where we are going to take not only the central nodes but the lateral neck also. So to this extent, we can do the surgery. We have cleared everything. You can see complete clearance, posterior, all the levels have been cleared. And follow-up with medullary CA patients will be, with the same yearly biochemical screening for syndromic things and calcitonin and CA is monitored. There is something which is therapeutic lutetium for recurrent or metastatic medullary carcinoma, which is obviously not of surgeon. And then comes anaplastic CA, where very few cases are operable, and we can just operate those early cases. Otherwise, surgery will not be an option for them. Regarding nodal dissection, I think we have discussed central node dissection. Nodal dissection is only done as a therapeutic measure and not as a prophylactic measure. That is the only one thing that I want to convey. And there is a lot of literature on this, that central clearance leads to a lot of problems. But there is one important paper under another surgical which says safe in high volume centers. This is very important. Neck dissection, if you can do it with meticulous neck dissection, you may not have all the problems. So this is a variable thing. It can't be said that everywhere neck dissection will lead to a morbidity. So current concept is only central node dissection, which should be a therapeutic and not prophylactic. And little neck dissections are already discussed. There are few patients which are aged more than 60 years. Here we can solitary nodule less than 1 centimeter, and it is not situated in an odd situation. Then we can keep these patients for active surveillance. And then I will not take much time here because the time constraints, but this is what is called dynamic stratification, how the disease is evolving with passage of time. Once we have operated, everything is okay, then we are going to move like this. If there is some different things happen, then again we see, like we see all diseases are evolving. Once we have treated, we can't say that now day one we have done this and this is the end of the story. It evolves with passage of time and we take care of that. And this is a picture from 2012 Olympics in London. Final step, exchange of baton, and they were going to win clearly, but this baton fell down and they lost. They were out of the game. So the best thing is you should know how to hand over the baton. The person who is going to take it, he should also know where to hold it, and then it is all win-win situation for everyone.
Thank you, Dr. Sanjeev, for nice presentation. One or two questions, sir.
Dr. Sanjeev, there are notes on imaging, but they are not positive on FNSE. What to do? In a thyroid, like a proven case, papillary CA, papillary thyroid cancer, notes on imaging, but they are not proven on the FNSE.
FNSE, if there are nodes on imaging, if there are high, clinically, that means clinically we are suspecting that.
Yeah, clinically nodes are palpable on imaging also there are.
We have to remove them. We have to do a neck dissection.
Because that is the problem, and in certain percentage then they turn out to be negative
Because
also.
FNSE may not be always correct. You may
Yes.
not be hitting the right area, and then once they are clinically there, we should remove them.
Thank you.
Sanjeev, there is an important issue nowadays, as you have pointed out, controversy between performing lobectomy versus total thyroidectomy. Because if we are performing lobectomy, nuclear medicine colleagues will not help us much. There is one So what was very clear cut for all of us indication that these cancer patients should be given lobectomy, very clear cut, no doubt. Literature is very clear, and then there are gray areas we do not know whether lobectomy is useful or whether total thyroidectomy is useful.
This depends on the risk certification. Node size 1 to 4 centimeters. The nodule size 1 to 4 centimeters, and it is unifocal disease situated in one lobe. It has got at least 2 meter ring of thyroid tissue around it. There is no extrathyroidal disease. There are no pathological features on FLC. And person is obviously age has to be less than 55 years.
Now this is 55.
These are the patients in which you can go for lobectomy. And plus there are no nodes neither on imaging nor on FLC.
See, Dr. Sanjeev already told this thing that you can divide thyroid cancers into good cancers and bad cancers. So when there are no risk factors, they are called as good cancers. So in those cases, we can go for.
Those are the patients in which we are not going to give any further radioactive therapy.
Yes, they most likely don't require.
No, but for do the scan, we need to the thyroid remove totally.
Yes.
It is not the concept. That's the point. Whether to do the thyroid uptake scan, the thyroid should not be there.
They should not require thyroid uptake.
See, most likely these patients, they won't require thyroid scan. This is what
No, why they don't, unless until we do the thyroid scan, we will not be able to know the metastatic disease. So whether it means the thyroid scan is not to be done in every patient. If we can, then what?
We are moving positive. I think if we have done a lobectomy only, it means we are taking this patient as a low risk, so very low risk patient.
Yes.
Okay, so it means this patient do not need a radioactive iodine treatment. So there is no point of doing a whole body iodine scan.
Yes.
And we can reassess after the results of lobectomy.
And such patients are followed up only by ultrasonography and thyroid.
Suppose we are going to do the thyroid scan in this case, all the iodine and the technetium will be taken by the thyroid gland. So in that scenario, we will not be able to get any metastatic lesion even if it is there in the body. So mostly practice is that after lobectomy, we do technetium thyroid scan to label how much thyroid is left. Just technetium scan, not radioiodine whole body scan with the intention to see the entire body. So sir was also partially right कि वो technetium scan करके हम सिर्फ देखना और document करने के लिए करते हैं, but not for metastatic work.
That in continuity there is another thing that if we do the only lobectomy of proven case of the thyroid cancer, whether we need to give post-operatively after surgery thyroid suppression we have to do or not.
Yes, we have to do suppression.
If we have to do suppression, it means patient is to be given.
Target for suppression is different, sir.
No, no.
If it's a low disease, target for suppression and TSH is different.
Then if he has to receive the drug for lifelong, then why not they do the surgery, total thyroidectomy?
You are right, sir. That is the thing. It has been clearly mentioned.
It is not only the one reason.
That we are not going to do. Probably these patients will not.
I think the reason of the lobectomy was the injury to the parathyroid and the nerve. If in good hands, that doesn't occur.
Definitely. See,
Best treatment is the total thyroidectomy.
As far as suppression is concerned, if we have one lobe left and we have removed one lobe, still the suppression can be given with the remaining dose. Like if the patient we are doing a total thyroidectomy, we need 2 microgram per kg to again. But in this case, particularly one lobe is there and that's working, we may need 100, we may need 75, we may need 50. So suppression still can be done when the thyroid lobe is in situ also.
And it has been established in the relevance control trial.
I think we have to wind up this lecture here. Thank you, Dr. Sanjeev. Thank you very much. And next, Dr. Nilesh will.
I invite Dr. Aftab Hasan Nazar for the next presentation. Dr. Aftab Hasan Nazar is Associate Professor, Department of Nuclear Medicine, SGPGI, Lucknow. He will enlighten us with the nuclear medicine supplementary role in TTC to MTC. So request to stick to the line.
Yes, thank you, Chairperson, for the introduction, and thank you, Dr. Sanjeev, for passing the baton. So I will try to cover nuclear medicine aspect within 10 minutes, and disclaimer is this 10 minutes can be boring, so bear with me, please. So first, differentiated thyroid carcinoma. As we all know, they are majority of thyroid cancer. They have very good outcome, and overall risk of relapse that never exceeds around 20%. So standard treatment consists of total thyroidectomy, near total thyroidectomy, and followed by radioiodine therapy. And then follow-up can be done by periodic measurement of TG, ATG, ultrasound neck, and whole body scan iodine 131. So because this patient has a good chances of survival and mortality is not the issue. So this AJCC staging predict the specific mortality. So basically we people try to stick with the 2009 ATA guideline for the risk stratification. Then as the Dr. Sanjeev said, we need the dynamic risk stratification. So now I will start where the nuclear medicine role comes from the starting of dynamic risk assessment. So for the theoretical point of view, nuclear medicine can offer you like diagnostic service like radioactive iodine scan, PET CT, FDG PET, gallium PSMA PET, iodine 124 PET CT, and TFB PET CT. And therapeutic option nuclear medicine can offer iodine 131 therapy and lutetium 177 PSMA therapy. But when you come to the practical aspect, you are left with the radioactive iodine and FDG PET CT. So basically, I will cover radioactive iodine and FDG PET CT only. So the concept, therapeutic concept is as already told. This sodium iodide supporter is an intrinsic plasma protein that mediates active iodine transport into the thyroid gland. And radioactive iodine therapy is based on the fact that thyroid follicular cells and DTC are efficient in trapping circulating radioiodine than other tissues. And NIS is found to expose more in the differentiated thyroid cancer. And these negative in poorly differentiated tissue and the carcinoma who has anaplastic transformation. NIS expression may also be helpful in predicting response and enhance patient management. And these DTC cells express NIS usually take up more radioactive iodine and responds better to therapy. So comes to the dynamic risk stratification. This dynamic risk stratification is based on TNM staging that integrate other clinical parameters also, histological variants, and now important point is result of first post-therapy whole body scan, then serum TG measurement, and result of first radioactive iodine therapy. So what is the advantage here of iodine scan? Significant number of patients move to low risk category from intermediate to high risk category when we use radioactive iodine whole body scan after total thyroidectomy. And they have significantly better positive predictive value and negative predictive value in predicting the final outcome. So what are the key points here? Initial risk stratification should be used to only decide whether the patient needs radioactive ablation or not. First. Second, the subsequent strategy and follow-up should be based on ongoing and dynamic risk stratification. So this radioactive iodine role of post-radiothyroidectomy radioactive iodine ablation is mainly to eliminate residual disease tissue that is left after surgery and that is visualized in the whole body scan. Radioactive iodine can also be considered as adjuvant treatment to eliminate microscopic disease that is detected in post-therapy whole body scan. So, but this microscopic disease in post-therapy whole body scan that are not of much benefit in a low risk group patient. So now the question comes how to decide the dose of the radioactive iodine, what is to be given to the patient. So first we have to decide first goal is radioactive iodine ablation. This is done in low risk group and this ablation facilitates follow-up by eliminating post-surgical thyroid remnant and this increases the follow-up sensitivity of thyroglobulin value. Second is the therapeutic, where you have the metastatic disease and you know this now the treatment option is palliative, then you shift your goal to the therapeutic only. You give iodine therapy, you palliate the patient, then again you will give after the 6 months again radioactive iodine therapy. And how the dose is calculated? Like we have done whole body scan 1 to 2 millicurie of iodine 131, and if the after the scan we see there is only remnant, then we will give 20 to 25 millicurie, 25 to 50 millicurie of iodine 131. If we see remnant and lymph node also there, then we will give 100 to 125. If we see there is lung metastasis, we will go to the 150 to 200. And if skeletal metastasis, so 200 and above 250. Here is the example. So first example, these scans are different patient done with the 1 or 2 millicurie of iodine 131 after withdrawal of thyroxine for almost 4 weeks. So the target TSH is to be achieved more than 30. So after the target is achieved, we have given 2 millicurie of iodine for the scan. So this first scan is showing only remnant in the neck. This is the anterior image, this is the posterior image. Then second scan is showing a remnant here, and there is a level 3-2 lymph node above this remnant. And this finding was confirmed by the SPECT CT. These images planar image, and we have also SPECT CT. So in the SPECT CT, where there is doubt, we do SPECT CT and we see anatomical CT component, whether this is the node or this is the remnant only. So in the first case, we will give around 25 to 50 millicurie. In the second case, because there is lymph node, we will give 100 millicurie, 125. Then third case, look closely in the chest field. There is chest field. You can see, you can make out of the lung this margin you can make out. So this patient has micrometastasis in the lung. So we treated this patient with the 150 to 200 millicurie we usually treat. Next patient, this patient has a huge metastatic disease in the pelvic hip. So this lesion is such a bit that iodine is not going anywhere. All the iodine which we have given, this goes into the that lesion only. So this kind of lesion we will treat more than 200 millicurie, and we know in one go this lesion will not go. But our goal is here palliative only. There is one example of response after iodine 131 therapy. She is 30-year-old female. After total thyroidectomy, this whole body scan was done after withdrawal of thyroxine for the 4 weeks. 2 millicurie of iodine was given, and this scan was done in the June 19, and this has this remnant only. Patient was given 30 millicurie of iodine after 6 months. This is the result. This remnant is not there. So comes to the management of radioiodine refractory disease. When thyroid cancer become radioiodine refractory, these cells lose the NIS expression and they more express GLUT receptor. So here we take Abdame ulcer. We use FDG here. So there is a role of FDG in radioiodine refractory disease. Most common indication of FDG PET CT, elevated TG level and negative whole body scan. And second, radioiodine scan is not collaborating with the expected disease burden. Like we have seen, TG level is more than 1000, but scan is showing only the remnant or only the node. We know because this node or remnant will not produce TG of much value. Then we can do FDG PET CT to look other disease which are not FDG of it. So FDG PET CT can show clinically relevant site of disease, assess serial progression of the disease, and identify the need of additional local intervention, like if we need EBRT or excision or RFA. And also, if you want to see response to targeted therapy, we can patient go for the FDG PET CT. And now, sir has asked a question: if FDG PET CT is relevant during initial staging, so we can do FDG PET CT who has high risk patient and who has advanced T stage. And if the patient comes with a distant metastasis during the projection, And if patient has aggressive phenotype, histological type like Hutchinson cell carcinoma, poorly differentiated carcinoma, anaplastic carcinoma in the histopathology, and FDG PET-CT has the strongest prognostic indication of survival. Low uptake or no uptake if radioactive negative disease, they have better prognosis. Now comes the question, thyroid incidentaloma. Use of PET-CT is increasing, so incidentaloma is increasing. And when the patient goes with the report with the doctor, so physician see, यार मैंने भेजा इसलिए था, ये thyroid कहाँ से आ गया? So picture is very clear. This incidentaloma identify as a abnormal focus and diffuse FDG uptake in the thyroid bed. The prevalence of FDG with thyroid incidentaloma in different literature, it is reported from 0.2% to 8.9%. And malignancy chances is seen in the 19 or 20% of the patient. High risk of cancer is related to if there is focal uptake or unilateral FDG uptake. And if there is SU value is higher and suspicious lesion in the CT scan. And if there is diffuse uptake in the thyroid, they are mainly associated with the benign lesion. So this is all about differentiated thyroid cancer. Now comes to the medullary carcinoma of thyroid. These are uncommon neuroendocrine tumor. They arise from
Sorry? 1 minute more.
Yeah, sure. So they are 1 to 5% of thyroid malignancy. So these MTC does not concentrate iodine. They have poor response to chemotherapy and radiation therapy. So what we can offer in diagnosis, these are the number of FDG, PET-CT, DOTA PET-CT, DOTA and DOPA PET-CT. I will concentrate on FDG PET-CT. There is a role in the recurrence and uptake is correlated with the high proliferative activity and poor differentiated. Recurrence detection rate is improved if there is high calcitonin and Ca level and if there is shorter doubling time, and that identify poor survival. Point for oncology scan, it distinguishes between rapidly progressive disease and slowly progressive disease. Combined use of FDG PET and doubling time may improve the identification of high risk patient. This is the example of the FDG PET-CT. We can see apart from primary, we can see skeletal metastasis also. Then comes the abdopa PET-CT. For the detection rate, abdopa PET-CT has a sensitivity of around 72%. False negative may be seen in the small lesion. False positive is very uncommon. Mind this thing. Then come to the DOTA PET-CT. DOTA PET-CT can be used in some patient if there is no therapy option left and we need to try to treat this patient with the DOTA PET. So we can use DOTA PET scan also. So this has a theranostic value and detect lesions with high somatostatin receptor expression that could be useful in selecting metastatic patient whom treatment with SSTR analog could be option. So diagnostic therapeutic. So take home message for the medullary carcinoma thyroid. There are insufficient evidence to recommend PET-CT for staging MTC before treatment. Use of PET-CT restaging or recurrence evaluation when serum calcitonin is high or calcitonin doubling time is shortened. So if the PET-CT indication comes, then F-DOPA should be preferred PET-CT PET radiopharmaceutical. But if F-DOPA is not available or it is negative, then we can use both. We can use FDG PET-CT. It is useful when we are expecting aggressive behavior of the tumor and we want to confirm it. And we can use gallium dotanate PET-CT if we are looking for a treatment of the tumor. Thank you.
Thank you, Dr. Shah, for this presentation and sticking to the time. Also open for 1 or 2 questions.
See, you said that you need to do again the risk stratification, for which what the most important is the RAL uptake scan.
Yes.
It means if it is a low risk
Yes.
and we have planned not to do, then we need not to do anything further if it is a low risk patient. Number one, that is question. Then we cannot do the risk stratification we cannot do the RAU and then we cannot do the risk further. Number one. So that is And one another thing is that what is the criteria in RAIU whole body scan about the uptake residual disease? Earlier criteria was less than 1%, 1 to 10%, more than 10%, doing the residual, again redoing the surgery or not. Number 3 question, if it is a low risk patient, then can we treat altogether without any lobectomy with the radioactive iodine?
Okay, so come to the first question. If there is any role of radioiodine in low risk category, guidelines say there is no role. If you are giving radioiodine, you are over treating the patient. This is the guideline. Now come to the practical scenario. Every surgeon after total thyroidectomy, even if low risk in our institute, send patient for the radioactive iodine scan at least to look if he has missed something. There is fear of missing out something, so this is happening. So every patient we do whole body scan, and if there is remnant, we do treat patient with the radioactive iodine lowest possible dose. This is the practical scenario. So dynamic risk stratification, if you have not done radioactive iodine scan, how you will done? Then yes, then surgeon and clinician will retain the patient, and of course he will follow up with the TG value and ultrasound only. Only this is the way to do dynamic risk stratification. You will eliminate a important component of iodine scan. So sir, I hope first question is taken care of. Sir, second question please.
No.
Percentage wise.
Percentage wise, what is the criteria in RA or you have to?
Yes, iodine uptake. So when I was at AIMS New Delhi, I had a luxury to calculate radioactive iodine uptake in the remnant. So if any remnant uptake more than 2%, we treated with the iodine therapy. If less than 2%, we leave patient as such. But now I have moved to another institute, so their uptake facility is not there. So we see visually, yeah, we objectively feel this uptake is more. Let's give the therapy. So more than so academically more than 2% you should give therapy.
No, but is it not how to calculate? Is there some separate machine or something other?
Yes, there is a machine. Sir, Dr.
We have a radio iodine uptake machine. What we do, the calculation is very simple. We have given a dose to the patient. We will take the dose, we will measure the dose, what is in the thyroid, and we will divide what we have given. And we will multiply with 100. Then we will come to know that how much iodine has been taken by thyroid. On the basis of that, we calculate. And initially we had a protocol if the patient is having more than 0.2, not 0.280.
Thanks for correcting.
Yes. No issue. जूनियर है कलेक्ट करते रहेंगे
यही तो लग्जरी है सर।
उससे क्या होता है हमारा ही वैल्यू बढ़ता है, लोगों को होता है इनको ज़्यादा आता है। तो क्या है कि 0.2 से ज़्यादा है तो हम उसको ट्रीट करते हैं, नहीं है तो उसको हम रखते हैं। अभी रिस्क स्ट्रेटिफिकेशन की बात है, थोड़ा सा मैं डिफर करूंगा एक आपसे। रिस्क स्ट्रेटिफिकेशन हम प्राइमरली करते हैं हिस्टोपैथोलॉजी के बेसिस पर। पेशेंट की हिस्टोपैथोलॉजी की है, आर्थर सेल है, टाउ सेल है, कैप्सुलर इन्वेजन है, वेस्कुलर इन्वेजन है, साइज क्या है, मल्टीफोकलिटी, इसके बेसिस पे हम बनते हैं रिस्क स्ट्रेटिफिकेशन। उस रिस्क स्ट्रेटिफिकेशन को 3 में डिवाइड करते हैं, लो रिस्क, इंटरमीडिएट रिस्क एंड हाई रिस्क। अकॉर्डिंग टू गाइडलाइन लो रिस्क को हम क्या करते हैं, ट्रीट नहीं करते हैं, इंटरमीडिएट और हाई रिस्क को ट्रीट करते हैं। होल बॉडी आयोडीन का जो है वो नॉर्मली इंटरनेशनली वो प्रोटोकॉल में लेते हैं या नहीं लेते हैं, कभी हम लेते हैं उसको, वो उसकी परसेंटेज है 0.2%, उसके बेसिस पे हम एक बार करते हैं। तो जो पेशेंट, जैसे सबने पूछा, कुछ पेशेंट है जिनकी अपटेक कम आ रही है, लो रिस्क की, उनको कोई जरूरत नहीं है, उनको टीजी करना है अपने बेसलाइन पे। उस पे एक क्वेश्चन और आ सकता है, उस पे ये क्वेश्चन आएगा कि उसकी टीजी तो अपने रिलायबल नहीं होगी फ्यूचर में, बट ऐसा नहीं है। उसमें क्या है, अपने बेसलाइन टीजी को एक स्टैंडर्ड सेट कर दिया। अगर वो बढ़ रही है तो हम उसको एवेल्युएट करेंगे, अगर बढ़ नहीं रही है देन वी विल से नहीं, दिस पेशेंट इज हैविंग ओके फाइन, he don't need anything. So this is what we do.
I think what the Dr. Karwasa has asked, at what time, suppose the uptake is more than 10%, at what time you will send for the surgery, resurgery?
Again,
I think that is the question.
Is there any indication of resurgery?
If risk stratification, according to risk stratification, patient fall into low risk category, if uptake is 20%, 40%, 30%, we will not send to the surgery. And if the patient is having intermediate risk, definitely we will try to send back this patient to the surgeon and we'll ask them, you please redo the surgery, remove as much as you possible, and then the rest we will take care with IOD.
And in continuity to this, that if we have not done the lymph node dissection and their nodes are positive, then is there any recommendation to send back the patient for the lymph node dissection?
I think, sir, if you have not done a surgery and if the scan, what the Dr. has shown, if there is a lymph node as seen on the scan, I think the best thing is the surgeon can operate it. If surgery is difficult, there is the chances of injury to the other side recurrent laryngeal nerve, or the patient is a risky patient, then probably we can go for relief iodine. But if it is surgically operable, then better to remove them.
Right. So
we
friends,
have
Dr.
Dambole also here in
we are running very short of time. We are already 1.5 hours late. Last comment, please.
No, I will comment in the panel.
Right, wonderful. Thank you very much.
So you have wasted my energy.
So, one thing is left,
So-
I want to clarify.
Please, Guru.
So, Dr. Sanjeev asked after how many days, sir, how many days of surgery radioactive iodine treatment can be given. So, if you are planning for thyroid withdrawal, then you have to wait until the TSS level is more than 30. So, that comes around 3 to 4 weeks. But if you are using RTSS injection to stimulate the TSS, then you can take patient as early as 1 week or 10 days.
Right. So I like to thank all the 4 speakers, Dr. Riya Boro, Dr. Vivek, Dr. Sanjeev and Dr. Aftab for nicely presenting their lectures and generating a lot of questions and enthusiasm of all the colleagues. So thank you very much and we will wind up.
Thank you very much.
आपको हमें थैंक यू बोलना चाहिए निकल गया हमारे
I would like to thank all the judges and the speaker of this session. Now moving forward, we would like to start the panel discussion. And for that I would like to welcome Dr. R.K. Karvastra, a surgical oncologist par excellence, Dr. Nisha Marwa, Professor of Pathology and Deputy Dean, PGIMS Rohtak, Dr. Noel Sinha, President, Society of Nuclear Medicine of India, Northern Chapter, Professor Dr. Snmi Nc, Head Endocrinology and Metabolism, Apex Hospital, Rohtak, Dr. Vivek Agarwal, is an endosurgeon at Maharaja Agrasen and Fortis Hospital, New Delhi, Dr. Aftab Hassan Nazar, Associate Professor, Department of Nuclear Medicine, SGPGI, Lucknow, and Dr. Justin Jalali, Senior Resident, AIMS, New Delhi.
Good afternoon all of you, and we have had a very nice discussion on various topics since the morning. And the last session on thyroid has evoked considerable interest and comments and a lot of gainful discussion. So now in this thyroid panel discussion, we are going to address more or less the same issues. We'll try to cover the ones that haven't been addressed so far. And I welcome all my esteemed panelists. I think it's a legendary panel if you ask me, starting from Dr. Vivek, Dr. Sanjeev, Professor Karvastra, Marlene and Dr. Nisha, and my own junior colleague and friend Dr. Aftab and Jasim, not to listen is the next week. So Jasim, may I invite you to first present the case and then we'll invite questions and we'll start.
Thank you, sir. Thank you all the organizers for giving me this opportunity. So coming to the case, this is a 35 years old female from Uttar Pradesh, presenting with swelling on the right side of the neck for 3 years. And the patient noticed the swelling on right side of her neck, which was insidious on onset and gradually progressive for 3 years. And there was no history of pain in swelling, and no history of loss of appetite or loss of weight, no history of dysphagia, dyspnea, dysphonia, no history of syncope or palpitation, no history of jaundice, hemoptysis, low backache, and there was no history suggestive of any hypo or hyperthyroidism symptoms, and there was no worsening of symptoms online now. And the past history, family history, menstrual history, and treatment history were unremarkable. And personal history, patient had a vegetarian diet with adequate sleep and non-violent bladder movement.
So I would direct my first question to Dr. Prabhakar sir. In your vast clinical experience, you have seen multiple cases like this. So how do you approach a patient with a thyroid nodule? What are the basic investigations that you would ask for and the history that you would like to ask for?
See, this patient clinically with solitary thyroid nodule, one child, this thing. So again, it is one in the imaging ultrasonography, one thing we have to do, and one in the thyroid function test. There are two things which sort out the things, whether it is a hyper or hypofunctioning nodule or it is a euthyroid status, and then the imaging wise, whether it is solitary or a multinodular things. And subsequent to that, depending on that, we have to proceed for the further action.
My question to Dr. Vivek Agarwal, in what scenario would you want a thyroid scan to be done for your patient?
For thyroid scan in a thyroid nodule, clear indication is when TSH is suppressed. So whenever we are suspecting thyrotoxicosis or hyperthyroidism. Other than that, probably there is no rule.
Right. So, question to Dr. Sameer, is there any family history that should be asked for with thyroid nodules? Anything relevant?
Yes, I think medullary thyroid carcinomas, they can have the family history. So any family history suggestive of renal calculus, hypertension. So these conditions, men's syndromes, they can run in the families and they can present with thyroid nodules. So I think it's very important.
And also I think history of radiation exposure is another important point that we should ask for. Because I remember during our residency, we used to see a lot of such patients who had childhood exposure to radiation for a lot of implications. That's important.
So, coming to the further investigation, further examination. On clinical examination, nothing was remarkable. The patient was well oriented, moderately built and moderately nourished. BMI was normal, and vitals were also stable. And coming to systematic examination, everything was within the normal limits. And in local examination, on inspection, there was a visible solitary swelling in the anterior aspect of the neck, which was more towards the right side, and the swelling had movement with deglutition and no movement with protrusion of the tongue. There was no venous prominences, visible pulsations, scars, and no erythema. And on palpations, there was a soft firm swelling, 4 to 5 cm in size, in the anterior aspect of the neck at the position of the right thyroid lobe. And rest of the thyroid was not palpable. And the swelling had a smooth surface with regular borders, and it had a limited horizontal mobility. It was non-tender and non-pulsatile. The inferior border was swelled and can get below the swelling. And there was no localized temperature, no fluctuations, no palpable neck nodes, no restrictions of neck movements. Pubertal sign and belly signs were negative. On percussion over the sternum, it was returned, and auscultation over the swelling, no bruit was heard, and there was no eye signs or no other dermatopathy or thyroid arthropathy. And on summary, this was a 35-year-old female with a gradually progressive swelling over the anterior aspect of the neck for 3 years, with no symptoms of hypo or hyperthyroidism, no compulsive symptoms, with no known comorbidity, with a palpable neck mass which was arising from the right thyroid lobe.
So, my question to Dr. Aftab. So, this thyroid system, on ultrasound, could you please enlighten us on that?
So this thyroid system is basically a lexicon in the radiology for uniform reporting and communicating to the clinician what is actually going on. So this thyroid system has a 5 category, 1 to 5, and as you go above in the category, possibility of malignancy increase. So in the thyroid system, like one denote that there is no risk of that normal thyroid gland, and thyroid 2, like if there is feature of simple cyst, if spongiform nodule, so you can get this is thyroid 2. Thyroid 3, that are probably benign aspect. So none of the highly suspicious lesions are seen, and these nodule are isoecogenic or hyperecogenic. Then go to the, after thyroid 4, I will go to the thyroid 5 directly, because there is high suspicious lesion. How you will define? If lesion is taller than wider, if there is irregular or microtubular margins, if there is microcalcification and if there is marked hypoechogenicity is seen, then more than 3 sign is present, then you will label this as a thyroid 5 and that has a high chances of malignancy. Anything below the 5 but more than 3, like this nodule is hypoechogenic but moderate, you label it 4 and these lesion has a low suspicion of malignancy.
Excellent explanation, Dr. Arthur. So I move on to pathology. We always proceed ahead with an FNA in case we have suspicion. And the recently given Bethesda system, it's been a decade that it has been used. So may I ask Dr. Nisha, can you just elaborate on this Bethesda system and how it helps the surgeon?
Yes. This Bethesda system, it was evolved in 2007 basically to overcome the variability in FNA reporting. Because FNA is one of the primary and important investigation in thyroid nodules. So Bethesda system is, in this we categorize the lesions into 6 categories. First category is of non-diagnostic or unsatisfactory. This could be non-diagnostic because of the presence of less material or the acellular material, or it is because of some artifacts which are obscuring the cytomorphological details. Then we have only fluid, we do not have any cells, we have the clotted blood, that's why obscuring the details. Then the second category is where the lesion is clear-cut benign. We can have adenomatous goiter or colloid goiter or lymphocytic thyroiditis and other lesions which are benign and we are sure about it. Then the third and the fourth categories, they are the basically gray zone. Third is the category of follicular lesion of undetermined significance. We are not even sure whether this is a follicular neoplasm, benign or malignant. We are just sure we are having some follicular cells against a background of cystic fluid or a few of the nuclei which are enlarged, atypical, and we are not sure about the lesion. Fourth is the follicular neoplasm. We are sure that it is a follicular neoplasm. Benign versus malignant, we are not sure. And we have to specify here because whether the herbal cells, they are the predominant component or not. Then in fifth, there is suspicion of malignancy. There are features which are characteristic of malignancy, but these features are focal and we are not having the exact categorization. In this, we can have suspicion for papillary carcinoma, medullary carcinoma, lymphoma, polydifferentiated carcinoma. Then sixth is malignant, that we are sure of malignancy and we can clearly give the diagnosis of malignancy. So this is in nutshell the Bethesda system.
Thank you very much. Thank you, ma'am. So, the Bethesda system for reporting of thyroid cytopathology, if you see the risk of malignancy from category 1 to 6, post-surgically, the risk was established that how many percent of these categories eventually turn out to be malignant. And you can see that AUS or FLUS, that is category 3, actually has about a 5 to 15% of risk of malignancy. Some articles dispute this, they say it's up to 25% also. And in category 4, it said that the risk of malignancy is about 50 to 30%. Now, sometimes, as madam has correctly pointed out, there's a gray zone in this AUS, FLUS category, that is 3 and 4. So, is there anything that can help us further? Can anything help us, any molecular testing can guide us here, ma'am?
Yes. Initially, BRAF mutation was studied, which is highly specific for papillary carcinoma, but it has got a low sensitivity. So now we have a panel of 7 mutations which we do in addition to BRAF. We do RAS mutation, NK and the RET, PTC mutations, then other mutations. We study all these mutations and on the basis of that we can categorize the lesion. Like for example, RAS mutation is seen in follicular adenoma as well as carcinoma. But if we find the additional mutations, we can categorize the lesion that this is a carcinoma, not the adenoma. And depending on that, we can categorize the lesions. This PAX8, PPR, gamma and RAS mutation, they are characteristic of follicular carcinoma, while the BRAF, that is VE600 mutation, that is characteristic of papillary carcinoma. So we have to do a panel of study, especially in case of 3, if we have the cellularity but we are not sure, we can do the molecular testing for further categorization. Even in type 1 category also, if we have the material, but we are obscure details and we have high clinical and radiological suspicion, we can go for molecular studies.
Excellent point. So we have these tests, the gene expression classifier tests, which actually sees the mRNA expression of 167 genes, and this has got very high sensitivity but low specificity. Whereas the previous panel that Madam explained, actually this is a kind of Boolean test, with graph being the major one for the PTC, and it can also help us in guiding a therapeutic decision of whether we can give vemurafenib in the post RRTC scenario. So staging of thyroid cancer, is one which says that stage 1 and stage 2, if less than 45, that has got revised to 55. So let me just highlight what were the changes done in the AJCC 8th edition. So you can see in DTC the age cutoff was raised, and a lot of points, finding points were added and changed from the previous 7th edition of the AJCC classification. You can read it on the slide. Apart from that, so risk stratification, Dr. Aftab has elaborately explained, what we should consider as a low risk, what we should consider as an intermediate risk, and what we should consider as a high risk, which is the obvious point that the intermediate and high risk will need to undergo radiation therapy, and low risk can be actually just observed. So, may I ask a question to Dr. Jasim? Dr. Jasim, can you use recombinant human DNA for scanning and subsequent therapy?
Yeah. The RSTSH can be used in the settings like when thyroid hormone withdrawal is not appropriate, like when the patient has intermediate risk and high risk settings, and patient is the patient can actually afford to the RSTSH, and patient does not want to have the hypothyroid symptoms, and also
so basically RSTSH is an option for patients who do not want to undergo hormone withdrawal, or in whom it can be deemed to be risky, and it's a very short procedure that enables quick scanning and quick therapy. RSTSH is however very costly. The injection currently costs around 85 to 90,000 rupees. Not everybody can afford it. Now again, the dynamic risk stratification, I think I saw a slide in Dr. Snmi's presentation also. So with this dynamic risk stratification, we have to grade the outcomes as excellent response, or biochemically incomplete response, or structurally incomplete response, and indeterminate response. And according to that, the management would change. So if there is excellent response, you can relax the follow-up. If there is incomplete response, you have to do close follow-up. If there is structurally incomplete response, you might require additional therapy. And if there is indeterminate response, you just observe and see what's happening. Now, Dr. Jasim, can you explain us what is radioiodine refractory thyroid carcinoma?
to label a patient as radioiodine and refractory thyroid carcinoma, the patient, there are at least the patient should fall within either of the 4 criteria. Either there should be the thyroglobulin should be elevated and iodine scan, whole body iodine scan should be negative, or the patient had the ability to concentrate iodine in 131 previously, which the patient is not concentrating now, or some of the lesions are concentrating iodine and some are not, or the patient has iodine concentrating disease, but he is progressing despite of that.
Right. So, according to ATA guidelines, this is what we call as radiorefractory thyroid carcinoma, and which means practically that radioiodine isn't going to work well for this patient anymore. And then there are further options that have come up in the last decade. Very heavily they have come up, starting with sorafenib, moving on to lenvatinib, which is the most popularly and commonly used drug nowadays, to cabozantinib, and a host of other drugs that have come up for treating radioiodine refractory thyroid carcinoma. So one question frequently asked to us is that is there any role for empiric therapy? So you have a patient who has a radioiodine refractory thyroid carcinoma. There is no uptake that you are seeing on the diagnostic scan. So should you still go ahead with an empiric therapy? So ATA guidelines say that you can try empiric therapy once with 100 to 150 millicuries. If the post-therapy scan of that empiric therapy shows uptake of iodine, then you can still consider further radioiodine therapy. But if it does not, there is no role for any further radioiodine therapy, and you can only go on to these drugs. And just to wind up the panel discussion, newer therapies are coming up, although not reached a stage where we can recommend them, but a lot of interesting research is going on. We have demonstrated PSMA uptake in metastasis from papillary thyroid cancer. We have demonstrated PSMA uptake in anaplastic thyroid cancers and tried therapy in a couple of patients, but it didn't work. Now the latest kid on the block, that is FAPI, that also has been tried. So you do some imaging with gallium FAPI and then you try to give lutetium FAPI, and modest response has been observed so far. So even in the nuclear medicine domain, if you ask us, if not iodine, then what? Then what? We are coming up with newer options. So this was just to show you an example. This was an anaplastic thyroid carcinoma, and we had done a PSMA PET scan. So what started off as a prostate specific is actually not prostate specific and seen in a lot of other malignancies. So the mechanism is different, and this concept is also being explored in a few centers worldwide. So I would wind up the panel discussion well in time. I think a lot of discussion we have heard over the last 1 hour. Excellent points by Professor Kawasa also in the previous discussion. So I would ask members of the audience if they have any questions.
You wanted to
thyroid carcinoma.
You all that you are going to answer you can listen, not one that.
So there were just a couple of points that I wanted to make in that last presentation. After explained very well. So one point that many surgeons ask us is that Indian guidelines recommend F-DOPA PET-CT. And F-DOPA PET-CT is not very commonly available, and most centers do it once a month or so. Why are they not talking of gallium botanol in MTC? That was the question that many people have asked me. And the obvious answer to is the practical situation. Botanol was not available in the US till 2016. So the guidelines which have come before that talk about F-DOPA. They don't talk about gallium botanol. Whereas in India being the second country to start using PRRT and start using Dotanox. Yeah. So we have experience from 2006, which is almost like 17 years now. And we have seen that Dotanox PET-CT contributes immensely when we want to stage or restage a patient with MTC, rising calcitonin levels, rising CA. Yes, you can do a Dotanox, you'll find good results. If CA more than calcitonin, try an MTC. So F-DOPA we don't need to use most of the times. That was the point that I wanted to make. And the second point was, Pradvasta sir had asked that how do you measure this uptake? So basically we measure it using the same machine that we use for the radioactive iodine uptake, RAIU. It's called as thyroid uptake, GO. It's a funnel-shaped machine which we place on the neck, and it detects the counts or radioactive counts that are emanated from the iodine that is accumulated in the neck. So after that we have a formula which we use and we calculate the uptake percentage. So you would remember classically in those days between 2005 to 2012-13, you must have had a first-hand feedback from AIMS excellent surgery. Many a times our HOD used to write, so when he used to find this uptake percent less than 0.3 or 0.2, he used to say excellent surgery. And then the next step that we used to do was visually assess the scan. Sometimes what can happen is that uptake in the remnant could be low, but we end up finding a node. So then the management would again change. And how to confirm if a patient has been surgically ablated. So one criterion is that uptake percent should be less than 0.2%. Second, visually there should be no other foci of uptake seen elsewhere in the neck or other sites in the body. And the third thing is the thyroglobulin. So the thyroglobulin conventionally considered to be undetectable, then good. But now literature says that if stimulated thyroglobulin less than 10, uptake percent less than 0.2, and no other radioactive iodine hybrid foci seen on the whole body scan, then the patient is considered to be surgically okay. So that was the point I wanted. So we have a comment from Dr. Nalu.
So your question was also for people who do not have the probes to calculate the uptake. So we can also do it using a camera-based method. It is a little longer. You measure the activity before you administer, and then at 24 or 48 hours you're scanning. You mark out the region of interest. You take the counts. It can be done. It's a little cumbersome. So a lot of centers do not do it. We rely on the visual interpretation along with the thyroglobulin and other markers.
I think, ma'am, one more point is like this. We are talking about the percentage uptake by the radioactive iodine probe. But I think for the practical point of view, most of the nuclear centers they do with the gamma camera machines, what the Dr. Nalin is saying. and the idea is to look for any uptake in the neck bed or thyroid bed which is more than to the background. So if it is more than to the background, you can take a call. That's simple, as simple as that.
So, after an excellent discussion, I think it's time to break for lunch because everybody is hungry. Just one before that, Dr. Vivek,
I think it was much needed.
Last comment.
Dr. Vivek Agarwal wants to make a quick comment.
It is about the controversy in thyroid, differentiated thyroid carcinoma which we were discussing. So just to clarify, papillary microcarcinoma less than 1 centimeter, lobectomy is good enough if it does not have other poor prognostic factors. Less than 1 centimeter papillary microcarcinoma can also be put on active surveillance, provided there are certain characteristics added to it, like it should not be close to tracheoesophageal groove, good histology, good cytology, and no history of radiation, etc. Any lesion above 1 centimeter, ideal is total thyroidectomy. If in between, less than 4 centimeter lesion detected after a hemithyroidectomy done for intermediate or low benign disease, then maybe it can be followed up without doing a completion thyroidectomy. Again, it has to be associated with low risk factors. So I think that clarifies how you have to manage.
I think the debate is between 1 to 4 centimeter, whether you need to do a completion thyroidectomy or not. That is the debate.
The current acceptance is that if you primarily are operating on a proved malignancy, go for total thyroidectomy. If you have done a hemi for some other reason, it turns out to be malignancy with no additional poor prognostic factors, you can follow. No need to go for completion.
True, sir.
Yes.
Even, sir, for a female 35-year-old, 2 centimeter lesion, proved papillary in FNA, you have to plan for total initially, or you go for a hemi for
2 centimeters. You mean 35 centimeters, 35 is 2 centimeters the lesion.
2 centimeters. So, yes, if you are working in a high volume center, you ensure to give good results without complications, go for total thyroidectomy. If you doubt your expertise, then maybe you can
see the same thing. I mean, for me, it appears that I will do the total thyroidectomy. Reason, I know that I am not going to injure the recurrent and the parathyroid.
And one more thing, suppose you are attempting a total thyroidectomy, but in the first part of the thyroidectomy you happen to injure, let's say now you know your geoparadized parathyroids and you are a little shaky about the other side, maybe then you can restrict to hemi. So it's about morbidity versus tumor biology, long-term outcome. So many factors you have to consider before taking a call.
I think I would like to make a comment.
Yes, please.
AIMS people have done a local ablation also, and they have come out recently with a retrospective data, and they have shown that it is equally effective if you are not going for a total therapy. If at first plate it has been done at Abhitharev.
I think for low risk where we have already decided for a hemithyroidectomy, probably even ablation is not recommended. So I don't know. I think which are the situations where we have to go for ablation.
As we have discussed adequately, I mean, if it's a low risk patient, we don't even need to go ahead with the ablation. But if we need to go ahead with some sort of procedure, if given a choice between completion thyroidectomy and between lobar ablation, this study that was done showed that lobar ablation can achieve as good results. So many times patients do make a choice and we don't want to go in for a completion surgery, in which case that choice is
But the caveat is that it should be a unilateral disease, and it should not be multicentric, it should not be associated with lymphadenopathy, and so there are other factors have to be considered before.
And this work is in guideline, ATA guideline.
And apart from that,
though it is a weaker
We
evidence.
accept that, but the question is that we rarely get those situations where
I think that is not required now. This was actually 5 years back, 4 years back. We have the concept of doing the radio ablation of the single thyroid lobe. Now it is not required. Actually.
So after an excellent panel discussion and quite informative, exhaustive session, I think everybody is hungry, especially me. So, can we break for So all of you are welcome to join us outside for lunch.
There's one more announcement. Rest of the 2 sessions they will be post lunch, and half an hour after half an hour we will be assembling here again. So please enjoy the lunch. It is outside in the restaurant. But this is how it happens.
आपसे कई बार बात होती है सर के बारे में तक मैं सर से बात तो दिल्ली
मीटिंग हो जाएगा तो
आओ सर
अच्छा ये आने वाला है तो अभी आजकल आप दिल्ली में आ रहा है
पहले फाइनल में तो उसके बाद
नहीं अभी धर्मेंद्र का है फिर एक एस्टेलाइन बायोप्सी भी है दो एक सेशन तो वही है अभी उसके बाद एक और टॉक है फिर वेट टॉक है फिर 10 मिनट का और उसके बाद ही पैनल है पैनल एंड पे अब मुझे रीशेड्यूल कर दिया तो पता नहीं क्योंकि एक वर्ष में जा डेटा जा रहा है इसके जा रहा है उसी पे वही है उनका देखिए कैसे
दो टॉक है ना वो दो टॉक है
अलग अलग रखना है, ठीक है? अलग अलग, हाँ। ये जो वो खुली पड़ी है सब फेंक दिया, ठीक है? किसने कहा रुक सब मालिक ने कहा, ठीक है।
हेलो, हाँ जी, जी नमस्कार, हाँ जी, जी जी बताइए, जी जी हाँ जी,
भाई और देख लो कहीं सीन पैक हो तो, ठीक है? मैं तो वैसे उठा लिया।
भी ऐसे बात कर लो
प्रोग्राम तो बहुत खाना है 2:30 बजे का था युवान का तो खाने के बाद अलग घंटे खाओ प्रोग्राम कितना किया क्या प्रोग्राम 3 बजे के साथ तो 1:30 बजे का नहीं बताओ अभी तो नहीं आते खाना वगैरह चल रहा है अभी हाँ अभी खाने के लिए लंच के हाँ करूँगा क्योंकि एक बार ऐसे आप मतलब यहाँ आ जियो मैं या तो मैं आऊँगा वहाँ पे या फिर और किसी ने भेजे नहीं मतलब ऐसा करेंगे चेंज करेंगे एक बार मर्जी हो गया मैं इधर इनको बोल रहा था कि मुझे ऐसे ऐसे कर देते हैं मगर हाँ ये तो है ही बता के जाऊँ कोई वो तो नहीं होगा बिल्कुल बिल्कुल बता के जाओ कि यहाँ वहाँ जा रहे हैं बाकी मैं देख रहा हूँ एक बार तो मुझे चल रहा है फिर यहाँ पे वो खाली करना तो यहाँ पे कुछ जरूरी है ये तो नहीं हम तक मतलब वायु तो जा रहे हैं और मैं खाली भी करना सुन देते हैं हाँ कोई नहीं भाई देखिए आगे भी है
सोना काम हो माल सोना सोना दागला काम हमको तो जाग हो कितना जाग हो
उनको आने दे
वन कितना
वाला एक अपना उनका ये जो पड़ा है पाकर पड़ा तो सारे का जाता है
कोई कभी नहीं होगी
वो है ना मतलब लैब है तो न्यूक्लियर का एक स्टाफ है क्योंकि दो जन रहे थे जन में
तो तीन वाली वो
तो वो चलाने जो फुल से उसके बाद
वो डॉक्टर लोग की डिया खड़ी हो जाए वो देखो आज जो कितना लोग का खड़े आ रहा है वो पीडी करवा दे उसको फ्लो
उसकी तो
उसका है 10 साल से तो मुंगा मुंगा कम रहा है
ये लोग